It is an honor to welcome you all to the Symposium on Ocular Trauma, jointly organized by the Ophthalmology College as well as the Association of Vitreoretina Specialists of Sri Lanka. Ocular trauma is a critical aspect of ophthalmology requiring swift decision making and precise management. Today, we have an exceptional lineup of speakers who will share their expertise, best practices, and the latest advancements in the field. This event is also accredited for CPD points. To officially commence this symposium, I would like to invite Dr. K.R. Dayawansa, the President of the Association of Vitreoretina Specialists of Sri Lanka, to deliver the formal welcome speech.
Thank you. Very good morning to everyone. The trauma is a tragedy because there's no predilection for the event. Now, if you take like a sort of some diseases, they have the predilection patterns. If you take a diabetes, we say people are with the sort of lifestyle changes, family history, smoking, those are more vulnerable to happening sort of diabetes. But for trauma, there's no predilection for whatever the way. And the reason Myanmar incident is a classic example. And the most unfortunate thing of this event, there are two components, physical and the mental trauma. The most unfortunate event is that there are no choices for those victims. Now, if you have any other problem, you can choose. You can choose a surgeon, you can choose a place of surgery, you can choose your medications. Here, no. That is, then and there, you have to get it sorted out. No choice in whatever the way. Therefore, it is our duty as clinicians to do the maximum justice for those victims because they don't have a choice. Those are in our hands. So we have to do our best for them. So I normally have sort of TTs, T. So what I say is treat trauma top level. Treat trauma top level. First chance is the best chance. First thing is the best thing to do. Otherwise, we all are going to put them into a trouble. So it's not easy. So we need to get our knowledge. We have to share our knowledge. We have to update on the sort of current guidelines, whatever thing. So this is what we are going to do. So this is a platform to everyone to share your knowledge. You can ask questions. Everyone is very ready to deliver their best for us. So this is the platform. I hope everyone will utilize this maximally. And I would like to welcome you all for this symposium and special welcome our guest speakers, Dr. Ranjit Ellavala, sir has come all the way to update us, and Dr. Ramesh Alagiyawan, he will join us very soon. He is a consultant GM from the Karapit, the Ragama. And hope everyone will enjoy the session, and thank you very much for your, and our most welcome is actually our sponsor, prestigious sponsor. He's a Delmage and Alcon Surgical, and everyone I would welcome formally. Thank you very much.
Thank you, sir, for that wonderful welcome speech. Your words have set the perfect tone for today's symposium, reminding us of the importance of addressing trauma with knowledge and collaboration. So as we know, facial and cranial trauma can have serious implications for both vision and overall patient outcome, making timely and effective management crucial. With his vast experience in the field, our guest speaker today, Dr. Ranjit Ellavala, will guide us through the key principles of early intervention and care. So please join me in welcoming Dr. Ranjit Ellavala, consultant surgeon and senior lecturer at General Sir John Kothalavala Defence University, Ratmalana.
Very good morning, all of you, and it's a pleasure to be here with the eye surgeons. Usually, I am not with the eye surgeons, usually, except for my treatment, actually. And Dr. Evans and those specialists from the ophthalmology unit, thank you very much for inviting me. Especially the coordinator was Dr. Aruna, who is colleague my working with me in my department. It's a pleasure to talk about trauma, and which I have been doing for the last 25 years. And I was asked to talk about preliminaries, actually, what we should be doing before that patient comes to you and for your ophthalmic treatment. And let's talk a little bit about that and update as well. And we'll go. Yeah. So what I'm going to do is what is called just to define resuscitation and what it involves, and ABCD sequence, which all of you are aware, right? And a little bit elaborating that as well, and a little bit touching on the facial and the cranial injuries. And most likely this complex is the one which is most important to you, and your eye is involved in that, right? Talk about a little bit on resuscitation. What is this resuscitation? What are we resuscitating? And resuscitating patients who has some changes. How did the changes occur? Bus speeding at in the Union Place and hit a man, got multiple injuries from top to bottom. That's obviously, looking at the patient, you have the anatomical changes. And that is quite obvious. But we know that now it is the physiological derangement and the physiological changes which occurs associated with that, which is the one which is going to kill. So you need a live patient for your ophthalmic work to be perfect, or the outcome to be perfect. So that's where we stand, and you need to have some sort of filtering system, and where you have system, and the patient has been treated before that patient reach you. Right. Okay. So we all thought, actually, your usual the pulse rate, blood pressure, and respiratory rate, when it becomes normal, we are very happy that we have resuscitated. It is not, actually. Now we know that it is not. The figures won't tell you the truth. There's something else. You are, and as well as myself, is made of small cells which we don't see, and the metabolism occurs there, and the changes occurs there, because even if you do the interventions and making that the changes in the physiology back to normal, still there is a problem inside the body. That is occult. That is called occult hypoperfusion. And it's difficult to understand. Emergency care is difficult to understand. Emergency care is very difficult. Just like Dr. Davan said that the patient has no choice. You have a problem, and it is very difficult to deal with the emergencies. So there is occult hypoperfusion, which increases the mortality. Right. How do we detect? There are parameters which are coming up now, and something like simply, I'm talking about the arterial blood gases, lactic acid. Those are things, are markers of that, and there may be much more than that, and it's time to come. So we are resuscitating a patient which need to before they reach you, right? Okay, ABCDY. Is it only for trauma? No. All the emergencies have ABCD sequence. And it's done in a sequential manner because for us to enable to deal with the changes and which sequence we are going to do it, because of what matters is the time. Time matters. Why? Time-related death. So you are addressing A, B, C, D, E, like that. And if I ask you what is A, B, C, D, all of you are going to say A is airway. In fact, you have airway, I have airway, which is perfectly normal. That is why I'm standing here. That is why you are seated there. What is the problem there? And the defect is the blocked airway, which kills. Why? If you don't handle that immediately, and there is going to be the earliest killer. That is why in that sequence. So breathing problems, ventilation problems, circulation, that is another one, and disability, which related to head injuries. Right, then there will be few things about the cranial and facial injuries, and I'm going to talk. You have two situations where you have eye injury. You have isolated, straightforward eye injury, which history says, the patient says that I have only eye injury. It's quite obvious, and you can deal with that without any fear. And but beware of missed injuries. Reason is, we are trying to make the system perfect, but the system is not perfect at the moment. And there could be problems, and somebody can miss the injuries, which are quite more important than the eye, because which is a life, what matters is the life. And so missed injuries are common, and if missed injuries are there, and the mortality is going to go up. So beware of that, actually. Then eye is only a part of the multiple injuries, so that's also going to come. But I think in a usual hospital, it's not a big problem, because the eye, all the specialties are there. But in this situation, is eye hospital is somewhat different. I don't know how the referral system comes from the accident emergency, and whether the patients are being sent here or you are going there. But that is a problem. Sometimes you can have problems like that, right? Okay. So airway, we talk about the airway now. What are you going to do actually? What are the interventions? And you can have oral and nasal airways, and suck out the secretions and blood, and remove the foreign bodies. And the ultimatum is the endotracheal intubation. So all multiple injuries need oxygen by mask. And then there is the cervical spine, which and I can't do anything, because already the patient has been hit by a vehicle, and already the damage has occurred. That is the primary injury, which you can't do. But from the time the patient comes to you, there should be some protection from the secondary injuries. So when you look at the eye, there should be, if there are multiple injuries, there should be the cervical collar going round. That was, before that, the medical officer should have done the manual immobilization of the neck, and which was followed by the cervical collar. If they come without the cervical collar, then that is a problem, and that never been thought actually, because all multiple injuries in this complex, and you need to exclude cervical spine injury. Right. Facial injuries. Now, usually it is the unrestrained passenger dashing on the dashboard or the windscreen. Now, the mid-facial injuries, there will be fractures and dislocations, which then there will be mandibular complex, and if the mandibular complex is unstable, and the structures which are keeping the airway patent is gone. And so you have the increased bleeding, and facial injuries cause bleeding, and secretions, and the foreign body is getting stuck, and so as a swelling. So imminent danger for that airway, and that is the problem to deal with. So airway compromise is top on the list there. And so there are a few the well-established indications for the endotracheal intubation. Right, obstructed airway, straightforward. Right, okay. Poor gag reflex, impending airway obstruction, and then the breathing, and so inadequate breathing. So if the monitor says that it is less than, saturation is around 90 or less than that, beware that you have to pay attention to that, and then need intubation and giving the oxygen level up. Right. Systolic blood pressure less than 5. Anybody who is having hemorrhagic shock cannot maintain normal physiology. Right. So they cannot maintain normal respiratory functions, and they need support. The airway is one of the supporting things, and which you can help. Right. Once the GCS is below 8 or less, and then you need the support from the airway need to be maintained. Now these are the guidelines actually, and but there could be certain changes, right? Supposing if I have a patient with 10 the GCS, I may do an intubation because this is safety, transport. And during transport, certain things can happen, which is very difficult to intubate while on transport. And also hypothermia is one other one, and once the patient is 34. And it was thought that in Sri Lanka we don't get hypothermia. Unfortunately, we do actually get hypothermia. Although the outside is hot, hypothermia is the one, a lot of people who, the trauma who died, they are hypothermic. And it's very difficult to treat hypothermia. So definitive airway is a tube inside the trachea. What is this tube? Usually it's an endotracheal tube with a balloon. And you can have something else as well. And tracheostomy very rarely. And cricothyroidotomy very rarely. And so ET tube is the commonest. Laryngeal mask, acceptable alternative, but it is not perfect. Now it is been accepted. And it do actually give the what is the solution, and airway is maintained. But there are disadvantages. So breathing have problems actually, and ventilation problems like, for example, tension pneumothorax, a common garden problem. And so they will have either isotube, and the open pneumothorax, open chest wounds will be covered, and thoracotomy could be and one of the treatment options. But that particular group probably won't come immediately to you. And if they are resuscitated, and then only they will, and the eye will be dealt later on, because what matters there is a life, and life to be maintained. You might have to do emergency thoracotomy and so on. Circulation. Why? What is the importance of circulation? So if you take all the mortality and after trauma, commonest is head injury. You can't do a lot, because the primary injury has already occurred. There also, what you are doing in your institution to prevent the secondary injuries, which I come to in a minute. Second commonest after admitting is bleeding. You can diagnose bleeding, still people are dying. That is a big problem. And it's more complex. It's not like opening a tap and putting the water into the duct. It doesn't work like that. Physiology doesn't work like that. It's so difficult to treat bleeding. That is why they are dying. So what is the treatment of bleeding? Stop bleeding, nothing else. You can't pour water and blood and saline. It's not going to. The system won't accept that. You need to stop bleeding, because very complex situation. And so it is the commonest cause of preventable death. That is the tragedy about that. You can prevent, but still they are dying. Right. That is a global figures, actually it's very high. Right. Okay. What do you do? And in limb injuries, you can do local pressure and tourniquet, and scalp lacerations, which are associated with the facial. You can do continuous suture and stop bleeding, because they bleed quite a lot. And neck bleeding, and if there are open wounds, actually you can put a Foley catheter and balloon up. You can put a second Foley catheter and balloon up. There's no harm. You can stop bleeding until such a time you get into the. And TXA, tranexamic acid, is a antifibrinolytic and well known to and have the 15% mortality reduction. That's proven. And so they give within 3 hours you give the first dose and the maintenance dose. What is important is the first dose and the bolus. And you give it to one arm, and the blood can't be given to that arm. It should go into the other one. Then it's proven. And so I just made one word where within brackets red, and it's a coagulopathy. If I cut my finger, tip of the finger, and drop a blood here, it will clot. If I just ignore that, it is going to heal. That's by natural clotting mechanism. Nothing else. We all cut the fingers, and nothing about that. But the man who has been hit by the car, the vehicle, which is going fast, have multiple bleeding points, he can't have that. Normal mechanism is going to protect him. We need to support him. Amazingly, that particular person who has got multiple injuries and started having more complex situation inside the body, and they are coagulopathic. Before he leaves the union place and come into the accident service, he is coagulopathic. You don't have to even touch the patient. That coagulopathy is called trauma-induced coagulopathy. That is a protein C pathway and a very complex way of. You don't have to touch the patient. You haven't done anything. It's coagulopathy. That increases the motility 4 field. And that is a terrible situation. And on top of that, you're also pouring saline and things like that, and there are so many other factors which are going to make the condition worse. Treatment of that is well defined now, and its resuscitation strategies have changed over a period. And so you give minimal crystalloid. Saline, no heart months, you are going to give maximum 1,000 even before that. But you must utilize the good service which you have. We have very good blood bank service. Must get the blood immediately and to O negative and O positive blood, uncrushed blood straight on. And giving minimal crystalloid, because the more you give the crystalloid, your blood going to get diluted and you're going to get the coagulopathy worse. So recommendations are only boluses and things like that. Right. And then you have blood and blood products, because you bleed whole blood. We don't have whole blood in the blood bank, and certain countries are developing now whole blood transfusion. And we have red blood, and you need the fresh frozen plasma and platelet combined with that, and cryoprecipitate, which contain coagulofactors. And that comes in a very fixed regime. And so how are we going to give it? White cannulas, you might have, if you are lucky and time to come, we might have 8 French gate cannulas, and which you can give a lot of fluids and within a short period, and we don't have it yet here actually. And you can use rapid infusers, which are very expensive instrument, and you can give rapidly. Or those the machine which gives rapid infusions will have the temperature adjustment, because you can't give cold blood and fluid to the body, and which will make the patient's core temperature going down again and getting the worse, and mortality going to be high. So talked about uncross-matched blood and cross-matched blood, and then what is the blood transfusion regime has changed, because when you bleed a lot and you give the blood and in a proportionate manner, and when you want to give blood, and giving blood also increases the mortality. So accepted regime is now massive transfusion protocol, or the MTP. Most of the hospitals now have a MTP in place, and the activation is important, and with the help of the transfusion people. So comes into head injury, and so neurological examination is important, and pupils, you need to look for lateralizing signs. And accepted NCCT brain is accepted if the patient could be moved to the CT scanner, and but you may have to do surgery without that. Certain things also are deleterious to the brain function, and all starting with H. You can see that the hypoxia, you need to maintain the oxygenation at between 80 and hypotension, and mean arterial blood pressure not less than 90, and hypoglycemia, you need to have the blood glucose level remaining at 6, and hypothermia is 37 temperature. So menthol hypertonic salines are still in use, and which is better depending on which paper you read, and maybe be a slight advantage on hypertonic saline, and 3% is available in Sri Lanka. And monitoring ICP has a place, and the severe head injuries are nursed head up. So there are certain other things we need to have: orogastric tube, and urinary catheters, splints, and fast scan, which is being done by the medical officers at the ETU, and the chest X-ray and pelvic X-ray. Just before I tell, I think it is not complete if I don't talk about the essential the investigations, arterial blood gas and lactic acid and coagulation study. Either you have the conventional coagulation study, the results will take about 4-5 hours, but otherwise you have the rotational thromboelastometry, which is now mostly available, is a ROTAM actually for its quick results, and serum calcium as well. So there should be, just to summarize in a different manner, what I've told actually, if you are dealing with the eye, there could be just alarming signs. Actually, if you hear a noisy breathing, the patients have a airway which is about to be obstructed. In few minutes time, get somebody to help you. Right, okay. And looking at the eye, the palo is one of the places which we look for the eye. And if it is pale, there is a problem underneath. Can't be congenital. Right, okay. And the respiratory difficulty, the respiratory rate is high or the low, both are in danger, right? Very soon you need attention and your patient, right? Unattended external bleeding. The patient is being transferred from one trolley to the other. There is blood on that one and blood on the other. There is a problem. I think nobody has looked at the back, so it's bleeding. And so if somebody is restless, don't attribute that to alcohol which has been taken 12 hours before, and that could be hypoxia, right? And somebody who is seated up, he's very adamant that he's not going to lie down for your eye care. There is a problem, right? Some people do have their airway patterns maintained while they are upright. Very rare condition, and don't force him down. He will die before your eye treatment. Okay. And the other thing is, nice thing is, we all love the electronic monitor, which gives continuous alarming, and it says there is a problem, we just ignore it. Don't do that. If you connect it to just pay the attention to that. Right, thank you very much for asking me to come here.
Thank you, sir, for that insightful talk on the primary management of craniofacial trauma. Your expertise and the practical approach were truly valuable. I know many of you might have burning questions, but in the interest of time, we'll have a combined Q&A session after the first set of speeches, first set of talks. So thank you for your patience. So moving on, our next speaker will delve into the management of eyelid lacerations and canalicular damage. I am pleased to invite Dr. Nirodha Jayavikrama, Acting Consultant, Orbit and Oculoplastic Surgeon from National Hospital, Kandy, to share her expertise.
Thank you very much. And thank you for the opportunity to talk today. After that entertaining lecture by Ranjit sir, I don't know, let's see, that was like 101 in trauma for eye surgeons. All right, so I'm Nirodha. So I'll be talking about managing eyelid lacerations and canalicular damage. And at the same time, I should apologize. I'm recovering from a laryngitis. My voice might not be the perfect voice today, so apologies for that. So the outline of my lecture would be, I'll be talking about initial assessment, the management, and then management of lid and canalicular laceration, and then the post-operative care and complications and management of these complications. So when we are assessing, we should say, Ranjit sir extensively described what to do when we are seeing a patient who has undergone trauma. So good history and elaborative history we have to take and to have an idea about what sort of an injury has happened, the mode of injury, and the mode of injury can give us some idea about what has happened underneath. Then we have to evaluate the extent of injuries. So what we can see is the lid injury, but underneath of the lid there can be underlying globe ruptures, orbital fractures, facial injuries, and possibly intracranial skull base injuries. I can remember when I was in Kandy, we get direct admissions to the eye unit as transfers. So the moment they see eye injuries, they transfer from other peripheral hospitals to the eye unit. So it bypasses the ETU and comes directly to the eye unit. So there can be a kind of a stick poking out of the eye, and it's not just in the eye; it can be in the frontal lobe. So you have to do you have to take the necessary actions to evaluate the patient properly. Then when there's lid involvement, you have to see whether the lid margin is involving. So the management is completely different if there's lid margin involvement or not. And then we have to assess the lacrimal system. Lacrimal canalicular system, if there's a canalicular damage, then the management is different. So we can assess either through direct visualization under anesthesia, or we can do probing, or we can do Jones test. The Jones test is we can put some fluorescein in the eye and test, we can put a cotton tip inside the nostril. The nasolacrimal duct opens up into the inferior turbinate, so we can check whether the fluorescein is appearing there. If there's a complete destruction of the canalicular system, it won't appear in there, so that's a rough test we can do. And if it's not too much of a damage, we can try lacrimal syringing as well. So this is an image of a patient who came with a grinder blade injury when I was in Kandy. So the lid has been cut through and through, and it has injured the globe as well. I keep that in my phone as a warning for the patients who use grinders without protective glasses. Then when it comes to eyelid anatomy, when it comes to repair of the eyelid, we have to know the anatomy, and we have to go by the anatomy. So the eyelid we can divide into basically anterior lamella and the posterior lamella, and then there's medial lamella as well. So the anterior lamella consists of the skin, the orbicularis oculi, and the posterior lamella has the tarsal plate and the lid retractors attached to the tarsal plate, and then the conjunctiva. So in the middle, we have the septum, that's the middle lamella. So when it comes to complications, the changes of this middle lamella can cause retractions, scarring, and lid malposition. So we have to make sure it's in proper position as well. So the problem areas, when we are seeing fat prolapse, when there's an injury to upper lid, if there's fat prolapse, think of levator damage. It has to be repaired separately, otherwise the patient will have ptosis. And then we might not have to repair it then and there, because ptosis can be due to hematoma as well, contusion, so we can repair it secondarily. Then lid margin involvement, as I said before. The canthal angle involvement, if there's canthal angle involvement, then we have to repair it separately. If there's medial canthal tendon damage, lateral canthal tendon damage, it's going to change the whole appearance of the aperture. So we'll have to reconstruct it in a way that the apertures go into the aperture is reconstructed properly. Otherwise, it can affect the lid position and function. Then canalicular involvement and tissue loss. The common thing we see is when we see a lid laceration, we feel like, oh, it's a big damage. It's likely having tissue loss. But most of the times, these tissues are not lost. They are there. So we have to carefully check. It's like a jigsaw puzzle, putting a jigsaw puzzle together. So if you go by the lash line, if you carefully inspect the area, we can find all the parts, because most of the times, during a trauma, the lid is getting avulsed from its attachments, and it's like a degloving injury. It's there, but it's kind of not in the proper place. So if you kind of carefully, and it's kind of stuck together. So we have to carefully use saline and possibly warm saline and detach it from all the adherences. And if we can put everything together, that's it. But there can be instances where there's tissue loss, if there's a lot of abrasions and stuff. Then we might have to use flaps to reconstruct the area. Then salient points, lid margin laceration repair. It's like a wedge repair, basically. So we repair it perpendicularly. So we have to reconstruct the anterior and the posterior lamella separately. If there's levator damage, we have to identify and suture it. If we can directly visualize it. Then medial and lateral canthal injuries we have to repair, as I told you. Then tissue loss. If you are using flaps to recreate the lids, if there's tissue loss, we have to make sure there's good blood supply for the flap to survive. So there are different ways of creating flaps. Local flaps, we can create. Local flaps are better if we can. So it's good to go for opinion in such cases. So lid margin laceration repair. I'll play a video here. So we can approximate the ends and see where the lash line and the gray line is. And then we have to take the approximate the tarsal plates first. We can use 5-0 vicryl to approximate the tarsal plates. So we have to put at least 2 to 3 sutures to the lower lid. When it comes to the upper lid, the tarsal plate is longer, so we have to put at least 3 to 4 sutures there. So you can approximate and suture the tarsal plates directly, but you have to make sure the sutures do not penetrate through the conjunctiva, and it has to be a partial thickness bite through the tarsal plate, otherwise the sutures are rubbing on the cornea. So you have to make sure once you pass through the tarsal, you can directly visualize at the cut end, directly visualize the tarsal plate. You can free it up from the adhesions if you want to using a cotton tip, and then partial thickness bite through one end, and you have to check the corresponding point on the other end and then pass at the same level. And you can, rather than tying it up, you can just cross the stitches and see whether it's nicely approximating. And you can go by the lash line and the gray line. Gray line is where you can check the meibomian gland orifices. So if you see the meibomian gland orifices are nicely lining up, that's where the suture should be. If not, always go and resuture it, because we don't want any notches. It is going to cosmetically, it's not going to look nice. Plus, it's not going to give a good functional outcome. Patients can get epiphora if there's a notch. So after the tarsal sutures, then we have to align the lash line and the gray line. When you are aligning the gray line and the lash line, we have to try to get a bit of an eversion. In oculoplastic surgery, we try to get, because around the eye, whenever we suture, the scarring, we have to prevent the scarring. Scarring is going to kind of drag the tissues down and cause notching. So if we try to evert, when the scarring happens, with the traction and all, it's going to drag down a little bit and settle at the proper point. So we have to always try to evert the lid, evert the suture ends. So we can use vertical mattress to do that suture there. Vertical mattress, far, near. We go from the far end of one end, coming out of the far end of the other end, then near, and tie it up, so it's going to evert the edges there. So we can, then after that we can close the skin and the orbicularis separately. For the lid margin correction, we can use 7-0 vicryl, and then for the skin, 7-0 so we can use. In this particular video, this is not one of my videos, this is Dr. Richard Allen's videos. So in this video, he's not anchoring the suture ends. I prefer to anchor the suture ends. When we are doing the gray line suture, leave the ends a little longer, and then do the lash line suture and anchor those ends from the gray line suture to that knot. So that would be better. It's not going to rub, so the suture ends won't be rubbing on the cornea. So the lacrimal canalicular damage. Lacrimal drainage system, everyone here should be knowing what the lacrimal canalicular system is. So mainly the tears are produced from the lacrimal gland, and it sits on the lower lid. The tear is always there. With the blinking, it's going to move to the medial canthus. We have the upper punctum, the lower punctum, upper canaliculus, lower canaliculus. Then it goes into the common canaliculus. It opens into the lacrimal sac and eventually drain through the nasolacrimal duct into the inferior turbinate. So if there's any damage to these canaliculi due to trauma, we have to repair it. Otherwise, it's going to get obstructed and the patient will end up with epiphora for life. Because the options we have in Sri Lanka are quite limited to correct it if there's an obstruction. So the primary repair is the main thing. If we cannot repair it during the primary injury, like primary repair, it's quite difficult for us to repair it secondarily. So during canalicular repair, we have to check whether the injury is medial to where the punctum is. If there's an injury medial to the punctum, likely there's a canalicular damage. So we can probe and see whether the probe is coming through into the wound. So there's a canalicular damage there. So then we have to find the proximal end of the detached canaliculus. We can use phenylephrine, adrenaline. It's going to pout the cut end of the cut medial end of the canaliculus. We can either use this, or we can also use some trypan blue diluted with some balanced or solution or normal saline, and we can irrigate the upper punctum with it, so we can see where the blue is coming through. We can also use fluorescein, put into some viscoelastics, so we can use that as well. If we don't have any of this, we can irrigate some saline and see. The other thing we can do is we can put some saline onto the medial canthus and pass some air through the upper canaliculus and see where the air bubbles are coming through, so we can detect the cut end. So ideally, we have to have monocanalicular stent to repair this. This is the best way to do it because it's going to self-retain itself there, and we can easily remove it even in a kid. We don't have to give anesthesia or anything to remove it when we have to remove the stent. But it's quite expensive and not available in government sector at the moment. It's 30,000 rupees in the private sector if you are to buy it. But this is the ideal thing. Back in the days, we used to use pigtail probes, and then we can use the DCR tube to kind of guide through the pigtail tube and canalicate it. But nowadays, we don't use the pigtail tube because it can damage the other canaliculus as well. So this is the ideal thing if we can use it. And then there are some improvisations we use. We can use the yellow cannula. We can use it as well. So when we are using the monocanalicular stent, we have to use at least 25 millimeters length of it. It's quite longer than that. It's 40 millimeters. So we can measure and cut at 25 millimeter point in a bit of a beveled, manner. So we can easily introduce it through the dilated punctum. So once the cut ends are detected, dilate the punctum. Then hold the minimonica stent with a non-tooth forceps, a Morpheus forceps, ideally, and then introduce it through the cut end. Yes, and you have to pull it out until that little self-retaining locks into the punctum. You can feel a little click actually. Once it's there, it cannot be easily removed unless we go in there and pick it out. So then it can be introduced through the
grasp the
through
tissues,
the proximal
just
end
making
of
sure
the
you're holding the canaliculus open.
tube, which is there. Once you observe the medial end, you can use a probe and see whether the probe can be easily introduced into the cut end. So you should be able to go through the proximal cut end into the common canaliculus and feel the hard stop where you can go towards the lacrimal bone there. So probe it and see whether you can easily go into the canalicular system. Then you know you are in the correct place, so you can introduce the other end of the stent into that. And then easily you can glide the lacerated ends along the stent and then approximate it. So when we are suturing, we can use 8-0 vicryl to put 2 sutures on either side of the stent, so secure it, then close the skin and orbicularis separately. Then leave the stent in place for at least 6 weeks to 3 months. I prefer 3 months. You can remove it after 6 weeks. Then if there's any canthal angle damage, traumatic telecanthus, there are different ways of anchoring canthi now. If there's intact periosteum, we can suture it to the periosteum. If not, we can use mini plates and correct it. So then post-operative care, topical antibiotic ointments, like chloramphenicol, fusiothalmic or tobramycin ointments, ideally twice daily at least. This is not just to prevent infection. Scarring is more when the skin is dry. That's a salient thing I would like you to remember. So once they are done with the antibiotic ointment, they can always use, if there's a scar around the eye involving the skin, they can always use any moisturizing cream or Vaseline or anything to kind of keep the skin moisturized. It will lessen up the scarring. And you can gently massage, you can ask the patient to gently massage the scar, so it will reduce the scarring and traction, because we don't want too much of traction, skin traction around the eye. It can cause lid malposition. So oral antibiotics only if there's a risk of infection. In follow-up visits, we have to check the complications, infections, wound adhesions, lid malpositions, cicatricial ectropion or entropion formation. Then we have to manage them accordingly. So if the primary repair is not done properly, if there's canalicular obstruction after the primary repair, then we'll have to go for either probing. We can try to probe and open up the obstruction. If it doesn't work, then we'll have to go for either DCR, secondary DCR with retrocanalicular probing and stenting. Then eventually, if it's not getting resolved by that, then the only option is a self-retaining stent, Lesser-Jones tube. It's a canalicular bypass, which is not available in Sri Lanka. Then if there's lid malpositions, then we'll have to correct them accordingly. This is what a Lesser-Jones tube looks like. It's like a glass tube, which is going to stay there to bypass tears into the middle turbinate. So in summary, I have talked about managing lid and canalicular lacerations, and we have to have solid understanding about the eyelid anatomy when it comes to repair, and then the other principles along with timely intervention and to prevent complications. Right, thank you.
Thank you, Dr. Nirodha Jayavikrama, for the elaborative talk on managing eyelid lacerations and canalicular damage. Up next, we have Dr. Medhavini Dissanayaka, who will be speaking on rational suturing of corneal lacerations, a crucial skill in preserving vision and ensuring proper healing. So please welcome Dr. Medhavini Dissanayaka, Acting Consultant Cornea and External Eye Disease at National Hospital, Karapitiya.
Good morning, everyone. So my topic is on rational suturing of the cornea. So I'll be focused mainly on suturing the cornea. So we'll look at why we need to suture properly, and then basics of suturing, and then some situations and a rough sort of guide on how to suture in those situations, and some videos. So the objectives of suturing a cornea or a globe is to get it stable. You want to get the shape and integrity of the globe intact. Things inside may be completely distorted. The eye may actually be blind with traumatic optic neuropathy, but at this stage you can't really know what's going on. So what we are going to do is just get the globe back in shape and prevent infections going in, and also do a good job so that if the patient has some visual potential, we can reach the maximum potential. So it's very important that we repair it properly as best as we can to get it back into the original shape. So you have to do it in the first chance. Like Diane said, the first chance is the best chance, because it becomes very difficult if it's not anatomically realigned into what it was before. To do it a second time is very difficult, because now you also distorted it with your surgery. So the first time is the most important time. So why is it important to get it back into the shape, near normal shape? Because this, you must remember that the cornea is practically the most important part of the eye that gives refractive power. So you want to have a proper corneal curvature to minimize astigmatism and minimize scarring, so that the cornea remains transparent and allows light to go in. So that once the globe, you do secondary surgeries, get all the components in the eye repaired, we can now do the visual rehabilitation process easily. So if we look at the shape of the cornea, sorry, one of the pictures has gone wrong. But basically the cornea is not a complete sphere for the beginning eye surgeons here. The radius of curvature changes from the center to the periphery. So it's more flatter in the periphery. It's good to know this when we are suturing. Now let's get into the basics of corneal suturing, very basics of corneal suturing. We use tenno nylon. The reason we use this non-absorbable suture is to prevent tissue reaction, minimize tissue reaction, so that there is less vascularization and scarring, so that we can have a transparent cornea as much as we can. If you look at the picture there, if you're using curved needle holder, this is how you hold it, hold the needle, and you use, so 2/3 here, 1/3 there, so you avoid the cylindrical part of the needle and you hold it from the flat part, so that it does, you have a very stable hold of the needle and doesn't rotate. And then it's very good to have this sort of 90-degree here, and I prefer a curved needle. It's easier to get into sort of different angles with the curved needles, but it's your preference really. Then this is how you enter the cornea. You enter at a 90-degree or perpendicular angle to the surface of the cornea, and you just follow the curvature of the needles. So you actually, that's enough curvature to get into the depth of the cornea, adequate depth, and then you just gradually come out. So this is a classic picture, and this is the proper way to suture. So you have the laceration here, and you have entered and come out equidistant from the base of the laceration. So if you don't do that, you will have, the tissue will move and you won't have proper alignment, and the misalignment is going to cause astigmatism, and then there'll be Dellen formation and things like that. And the epithelial healing will be impaired and things like that. So you need to have this nice equidistance. If you don't go the full extent of the depth, or 90% of the depth at least, the tissue is going to gape at the back end. This is going to cause posterior astigmatism and problems later on with visual rehabilitation. And of course, the healing is also going to be not very good. If you do a full thickness, if this is 100% thickness suture, what happens is you're forming a tract for infections to go into one of the most protected areas of the eye, which is the anterior chamber. So you don't want to create a tract like this, you just go 90% depth. Now in a shelf laceration, the distance is measured from the base and not from not at the tip. So from when you examine from the microscope, you think this is not equidistant, but it is actually from the base that you take the distance from. So if it's a really slanted shelf, the corneal suture might be quite long. This is what it appears like on the slit lamp. This is when you have to suspect a shelf laceration. The knots can be anything really. You can choose whatever knot you want, but the smaller the knot, the easier it is to rotate. Slip knots are very helpful knots in traumatic corneal repair, and I will explain if anyone's interested. I'll do that at the end. Burying the knot with a very good fine non-tooth suture, you go parallel to the suture and then you rotate it along, and make sure that the knot is not buried in the wound itself, but it's away and kind of directed towards the surface like that. This makes it easier to remove it later on. Now let's delve into some situations now that we know how to do the proper suturing. So let's look at partial thickness and full thickness laceration. So partial thickness lacerations, now there is nothing going inside. Basically the cornea is intact, it's just that there is some tissue now trying to gape. It could be trying to gape open. So if you leave it like that, it's going to scar like that and leave a lot of astigmatism in the eye. So the principle here is to prevent the cornea from gaping until it scars and heals itself. So until the gaping, basically until it scars, you can use something like cyanoacrylate glue with a plastic patch as shown in the picture, but this is theoretical, not available in Sri Lanka, but maybe in the future. You can use a bandage contact lens temporarily, or you can, if really necessary, you can use sutures. You might need to use sutures, especially if it is a more central corneal partial thickness one, because the central ones tend to gape more just because of the anatomy of the cornea. Now let's look at some full thickness corneal lacerations. Self-sealing ones, or with ones with minute leaks, you can manage the same way as the partial thickness corneal lacerations, bandage contact lenses and glue or 1 or 2 stitches. Simple laceration, let's look at a simple corneal laceration, just some basic guidelines. So in a simple corneal laceration, you must do the limbus firm. Basically any laceration involving the limbus, you suture the limbus first. You can do with a long suture, which will, because it's a flatter area anatomically in the periphery, you can use a long bite and get the limbus approximated. This is the most important thing. You must, sometimes when it's really distorted, it might be hard to find where the limbus is. So you must look very carefully and align it very carefully, align it properly. So limbus to limbus. Okay, that's the most important thing. And then you can do the perpendicular cut of the laceration first. So usually I can't say usually, but in a sort of a linear cut, the central bit would be a perpendicular cut, in which case you start off with the center and then you close up. So when you come closer to the center of the wound, center of the visual axis, you have to use smaller sutures, and then try your best to avoid suturing the visual axis itself. Once you suture the perpendicular lacerations, it's very likely that the shelf laceration will seal itself and will be easier to suture. Now, stellate laceration are complex lacerations. Now, the issue here is that the tips of those wedges are very, very brittle and fragile, and you have to be very careful when you suture and when you touch those areas to suture. So it's very important that you use very fine and precise tools to hold the tissue. The eye hospital casualty unit may not have the very good instrument, and you might have to actually, it's worthwhile investing on a good colibri. So simple way of suturing a stellate laceration would be, okay, now it's stuck, okay, is to start flossing from the periphery with just a few stitches, and then all of those sort of petals or leaves or basically the wedges will come into place, and it will be easy to get through a larger stitch to cover a few of those wedges and get everything aligned. This is a quite easy, straightforward way. Burying the knots is also easy in this situation. If you can't get a stitch to sort of get the tip aligned, you might use a bit of glue there in the center. Or if there's tissue loss, you can use a tenon patch or a conjunctival patch to cover that temporarily for the scarring to happen. This is a purse string suture. There's not really any rule there. The purse string, the difficulty here is burying the knot. So you have to be very careful when you're rotating. Take your time and rotate the knot. You can do a completely intralamellar stitch as well. Here you have to cut through the cornea, partial thickness cut here to get the knot inside and then rotate it. So for that you need again a MBR or a very sharp blade to do that, and a good pair of colibri to hold well. Otherwise you're going to crush the tissue while you're making a nick with a blunt instrument. So this is a completely intralamellar suturing of a stellate laceration, which the picture shows as an example. Um, okay, another situation, corneal laceration with uveal prolapse or uveal incarceration. Here what you do is you have to go in from a different paracentesis and put in some viscoelastics. The viscoelastics might be enough to push back the iris, but you might have to go in with an iris repositor and gently push it back from a different side from the wound. And then you repair the cornea as you normally do, but you remove the viscoelastics at the end. Lens involvement, I think, there's nothing much for me to say. Vitreous involvement, I would just say that when you're suturing the cornea or the sclera, make sure there is no vitreous coat in the wound. So you just do dry vitrectomy, don't pull the vitreous. Just cut it off and make sure your needle is not catching any of that. So corneal scleral involvement, you have to do, now you have to find the principle here is to find the apex of the laceration. So you have to retract the conjunctiva, explore properly and find the apex and then start suturing. Now, before you, if it's quite a large one, you actually start off with the limbus. You do the corneal part, you approximate the limbus, suture the cornea, and then explore, do the peritomy and explore into the sclera and find out the apex. If the scleral laceration is likely to be going under an extraocular muscle or involve the extraocular muscle, you might need to tag the muscle, detach it, do the scleral repair, and then reattach it. So that's a bit more complex, and you have to remember that the muscle may retract. Okay, so this is basically how you do it. You've got the limbus, and ideally there should be a suture there. You do the limbus and then you do the sclera, do the peritomy, find the apex of the scleral laceration, and then you start repairing. You might just need to do dry vitrectomy, push back the uvea, and things like that before. You don't cut off tissue unless they are devitalized and necrosed or something. You do not remove any of the tissues in primary repair. So this is the final situation I'm going to talk about, is where there is tissue loss and you are unable to put back the pieces together and suture it properly, giving the cornea or the globe a proper contour. And in that case, you might need to patch up. So the best way to patch up is, easiest way would be a conjunctival patch, and it does hold well. Or you can just do a T-node patch. Or if you have the availability, you can straight away do a corneal patch. And if this is a scleral problem, then you can use a partial, you can sort of cut a flap off the sclera next to the perforation and use that partial thickness flap over and suture that in. So videos, this is not videos. These are sequential photographs because I couldn't edit the videos really. So this is graft dehiscence that came after minor trauma. This is a DALC, I think about 18 months after surgery. So this white bit was actually bloodstained anterior hyaloid. The lens and lens had expulsed, and vitreous was outside the wound. We weren't at the stage where we was doing the suturing. We didn't really know where the retina was, so we were very careful of this bit here. So that's what it looked like. So here we have put sort of suture right at the center of the dehiscence to make sure that we've got the proper alignment of the graft. Now here I'm using slip knots, which has now become my favorite way of suturing really. So you can see I'm using the needle to clear off any debris from the path of the needle track. And I've used these are, so hang on, missing one picture here, but basically these are my slip knot ones. So this is slip knots are not tightened knots. So basically what you do is it's a 1-1-1 kind of knot where you do 2 of the ones, and you leave it like that, and you do the first cardinal few, and then you can adjust the tension. You can reform the globe, adjust the tension, and then you put the tightening knot at the end. So for the 1-1 or the slip knot, what you do is when you put the sort of when you get the thread over your forceps, either you go under or you go over. So you follow the same thing for the next one. So you do one throw over, and then you pick up the end. So the next one also you do the same thing. You do over and pick up the end. Make sure that the end, the free end is on the same side of the knot. Otherwise, you will be rotating the forceps, and then it locks. So you use this method, and then it's very, very useful, because then you leave the loose ends quite long, and you do the cardinal few, reform the globe, then you lock everything up, cut the ends, and now I've started to put the rest of my sutures. So it saves time. So that you don't have to, some sutures end up loose or some end up tight. This avoids that problem. So that I did a little bit of vitrectomy here, but I was very worried about this thing here. So I just did under the wound. And then, yeah, that's what it looked like at the end. Okay, this video is from the, it's not again a video, the photo sequence is from the expert himself, Dayavansa sir, repairing a globe rupture about 5 years back. So this is a linear laceration. You can see that it's now extending into the sclera on either side. We don't really know how far it's extending. It might be going slightly beyond. So as we discussed earlier, so he's starting off right at the limbus, and you can see he's slightly everting the cornea here just to avoid, you can see the uveal prolapse here. He's avoiding capturing the uvea with the needle, the iris. So now he has sutured the cornea as we described. Let's put the cardinal sutures and formed. Now you can see how he's now exploring into the conjunctiva, blunt dissection and peritomy. Now he has exposed the apex of the scleral laceration, and he's now repairing it. And he's doing the same thing on the other side. And sir is using nylon for the sclera here, which is also fine. And now he is finished with the cornea scleral basic suturing. And you can see here that he has used an air bubble in the anterior chamber to hold the shape while he's suturing. This is a good way of doing it without using viscoelastics inside, because you have to remove it at the end. Now he's just putting the conjunctiva back in place. And that brings me to the end of my tour. And we must remember that every globe rupture is unique and is different, and is a different challenge to the cornea of the surgeon, really. So the more you do, the more experience you get. So I leave you with a quote from the Sri Lankan Sushruta. Thank you very much for listening.
That was an enlightening talk, Dr. Medhavani. We appreciate you sharing your expertise in suturing corneal lacerations. Our next topic is managing traumatic subluxated lenses, a complex condition requiring careful intervention. To present this, we have Dr. Aruna Fernando, consultant vitreoretinal surgeon from General Sir John Kothalavala Defence University, Ratmalan.
Right, till we get the slides ready, I just want to say a few words to Nirodha. Thank you very much for stepping in at the last moment. Yesterday, you did a brilliant presentation, and for the trainees, that's an excellent presentation on lid and canalicular manage. And Nirodha also wonderfully presented the lecture. Thanks a lot for both of you sitting in. And some of you might not know Dr. Ellavala. He is called in our department, he is called the king of sarcasm. If you have not got the message in the last slide. That was to a lot of us sending the message that not to miss a lot of things that you might miss in the eye hospital A&E. Thank you, sir, for coming in and putting a bit of light onto things that we may miss. So, if the slides are ready. Okay. Right. I'm going to talk. Nicholas, forward, Jenny. Forward. Okay. Right. Thanks. So I'm going to talk a bit about managing what we do when we have a traumatic lens problem. So when it comes to the lens, you should have already sorted out the initial three problems. So we are going deeper. Basically, you have to make sure the patient is alive, as Dr. Ellavala said, and then make sure that the lids are sorted out and the cornea is sorted out. So we have to have a kind of an intact globe to go to when we go towards the lens. Then again, always stick to the basics. Make sure that you know your anatomy. So you have a lot of doctors here who are, sorry. Right. Okay, got it. Thank you. Make sure that you know the anatomy. All of you all are doing eye casualties and a lot of trainees, registrars and SRC as well. So make sure that you know about the how the lens is fixed to the globe. It's the primary microfibrils contain the polymerized fibrillin. They are very fine, but they are very strong at the same time. So 1 to 2 micrometers in diameter, and they make sure that this heavy lens is held in place. So it's actually quite difficult to break the, if you are doing cataract surgery, if you are doing surgery itself, you will realize that it's not easy to break the zonules, even if you want to. So for someone to have a break in the zonules, that means they would have to have a significant force on the eyeball itself. So if you are talking about going to the definitions, subluxation basically means the lens has moved away from its anatomical position, but the lens is going to be in the pupillary plane. Luxation or dislocation means that the lens has moved away from the pupillary plane, and that means it may either be in the front or the back. So the causes, you have to understand, there will be congenital causes of this. Trauma is not the only cause. So you have various conditions which make the zonules weaker congenitally or due to other connective tissue disorders, Marfan's, homocystinuria, Weil-Marchesani syndrome. The lens may already be dislocated or subluxed. And then there are age-related conditions which make the lens more subluxed. As the lens matures, it becomes heavier. If you have exfoliation syndromes, then the zonules are inherently weaker, and as you grow older, the chance of subluxation is higher. So, if you have these conditions on top, then if you get trauma, these patients are more likely to develop a subluxation. So that's one thing that you need to remember. Okay, so how does this happen? So usually we are not talking about penetrating trauma. Obviously, if you have a penetrating trauma, you will have a direct lens injury if it is deep enough. But commonly here what happens is the blunt trauma. So you have force entering the eyeball from the front. The AP dimension is shortened, so the equatorial diameter is going to be wider. So that's where the zonules get stretched. So that sharp force anteroposteriorly makes the eyeball distorted, so the zonules break at the equatorial line. So that will end up with the dislocation. So for a significant subluxation to be there, you will have to have at least 25% of the zonule fibers torn. So subluxation, what will that do? If it's subluxing, it can move, that means if it's subluxing, it moves, the lens is moving anteriorly, then it can push the iris plane forward. That can cause an acute angle closure. At the same time, if it's been there for a little while and patient has not detected or we have not detected, it can lead to a chronic angle closure as well. The lens is not in its normal position and the lens may be rubbing against the iris. So with the iris movement, with the dilation and the constriction, the pigment will be dispersing. So you will have pigments on the pigments depositing on the cornea. The more problematic thing is these pigments are going to go into the trabecular meshwork and then that's going to cause a secondary glaucoma. If the iris is always going to be rubbed, then you are going to have the blood aqueous barrier also broken. There will be a low-grade uveitis or inflammation going on. So these are things that you need to be aware of when you are thinking about anteriorly sublux lens. So dislocation of the lens, it can be either anteriorly or posteriorly as we discussed. So if the lens is pushed anteriorly, it can be either the crystalline lens itself or it can be an IOL that might have been there. So the lens can be pushed, again as we talked about earlier, the anteroposterior force will push the lens, it will dislocate and then it can bring with the vitreous pressure, it can bring the lens to the anterior chamber. So if you have a lens which is in the anterior chamber, that can cause endothelial decompensation. It can continuously rub on the endothelium and gradually the endothelial cells get dislodged, and as you know, the endothelium is the one structure that that does not regenerate. You lose the endothelial cells, the other cells are going to just die, enlarge and fit in. But eventually, if you leave it long enough, the endothelium will decompensate. I talked about the aqueous blood aqueous barrier breakage again and the pigmentary displacement. So what happens if you have the lens dislocating to the back? So if the lens drops to the back, then it's in the vitreous. It can be again IOL or the crystalline lens itself. One thing that will happen is now the lens diaphragm is no longer there, vitreous can come forward. So if the vitreous comes forward, so if the vitreous comes forward, then it's going to come and block the pupil. So if the pupil gets blocked by a bulb or a blob of vitreous, what's going to happen? You lose the aqueous pathway. The aqueous pathway is going to be lost and that's going to cause what we call a pupillary block. Sometimes you may miss this. This is the reason that we don't, even if in a cataract patient who needs a zero lens, we still put the lens. Right? We don't just remove the lens and just sit back because it can cause a pupillary block. This can make lead to an angle closure attack, and it's very difficult to manage once that happens. So be mindful of this. If the lens goes to the back, then it's the vitreoretinal surgeon's problem as well. So when you see patients like this, don't miss out on these things that when the vitreous goes back, it's going to induce a PVD as well. The posterior vitreous attachment and the trauma itself can cause a retinal tear, and at the same time the retinal detachment as well. So these are posterior segment sequelae that you may be missing because sometimes the cornea may be hazy, the lens is not in its place, you can't see the vitreous cavity. Make sure that you do a gentle B scan if you can't detect the things at the back. Okay, so going to the history taking, obviously these are basics. Make sure that you take a proper history. The patient may be in a lot of pain, get the history from someone else, but you have to obviously attend. The velocity of the projectile, size, is it a soft one or is it a hard one? Is it a leather ball that has come and hit, or is it just a squash ball that would have gone all the way in? So these are injuries that are there. So if you had a leather ball hitting the orbit, it's unlikely that the there will be orbital injuries, but the globe injuries may be minimal. A small soft squash ball or a shuttlecock will cause more damage into the globe itself. So asking questions on the visual acuity, obviously, if the lens is subluxed from the pupillary plane, the patient will complain of monocular diplopia and glare. So these are things that you will need to attend to. Looking at the patient, look for the very subtle signs. You have to pay a little bit of attention, make sure the patient may be in pain, so struggling. Make sure that you pay attention, look for the signs very carefully. It's a busy clinic, it's a busy casualty, you're going to be tired as well, but at the same time, these patients need attention. And as everyone before me said, first time is the most important thing. So iridodonesis means the iris is just wobbling about, like a flag, it's moving about. Phacodonesis is the lens moving about. It may be, that may not be very visible, but make sure that you check the iris movement. If the iris is moving about unusually like a flag, then something is wrong. Uneven depth of the AC, that means the anterior chamber is not equal, and then obviously the lens not in its proper place. Vitreous and pigment in the AC is also, these are signs. Make sure that if you can't examine the posterior segment, at least do a gentle B scan and make sure that the posterior segment is not missed. And now, when it comes to, don't forget about traumatic optic neuropathy, as someone said earlier. This may be something that you may need to attend. Sometimes we do a lot of things and then it might not be worth it also. One other thing, if you are suspecting a sublux lens, not only at the slit lamp, make sure you tilt the patient back a little, put him on the table and shine a torch and see. Sometimes the lens may be just hanging on by the superior zonules, and you put the patient on the back, the lens will be in the vitreous. So sometimes we think, this is all right, this can be done as an anterior segment surgery, but when you put the patient on the table, the lens has dropped. So you need the VR guys to come in as well. So just examine them like this as well. Grading system, I don't think this is mentioned, but I don't think this is really necessary. This can only be detected when you are doing the surgery itself. But look for the number of clock hours in the zonule. So that will give you what you need to manage. So examination tools, obviously we use the slit lamp. If you have ultrasound biomicroscope, brilliant, you can see the details so well, but we don't have one in the country. But anterior segment OCT is useful. So use it, it's very, it's cheap, it's freely available as well, and it gives you some idea of what the angle looks like and where the lens is. So what do you do? How do you manage? You have to, obviously, when it comes to the lens, we are not going to be rushing in. It's not the first thing that you need to do, like the closing of the globe. Control the inflammation, control the intraocular pressure, and then we think about this visual reality. It's very important that you don't sell surgery to the patient. Make sure that the patient understands what he's going to go through. Make sure that the patient knows that this is going to be a difficult journey, that it's going to be, the lens is, they will think that it's another cataract. No, it's not another cataract. Make sure that you tell that it's not another cataract. This is going to be very complicated. You will have to have long-term follow-up, and make sure that you don't oversell the surgery, but make sure that he gets it done. When to do the surgery is important, that you will have to discuss with, maybe not on your own, maybe discuss it with a colleague of yours as well. When do you need to do it? Early or late? Sometimes late is better. Think about medical legal aspects as well. This is going to affect his life, his job, his driving. There is an expert who is going to be talking about that at the latter end. So, decision making. If the lens is dislocated, it has moved, we have to remove it. Dislocated lenses, we have to remove it, and then IOL has to be fixed and it has to be planned. So I'm just going to... Okay. I'm just going to go through this video. It's not one of mine. So basically, if you have to do this, you have to make sure you remove the anterior do the anterior vitrectomy, induce a PVD, make sure that you do a proper PVD here, because you have to remove the vitreous as much as possible. We put a little bit of perfluorodecaine into the heavy liquid to protect the posterior pole, and the lens is either removed with the cutter or a fragmatome. So we do that, and then that's it. Okay, so one point for the VR guys, it's important that you do remove the vitreous as much as possible, because if you are putting a fragmatome, it uses a lot of force. There's a large vacuum that is generated, and you can induce tears if you leave the vitreous behind. So make sure that you do a proper vitrectomy when you are removing the lens out. So sublux lens, no obvious complications, patient is happy, leave it as it is. Don't disturb the dogs that don't bark. Cataract or associated other complications, now you have to intervene. You have to do something about it. So how do you make a decision? If the subluxation is minimal, if it's about 1 millimeter, 1 clock cover, or even sometimes 2 clock covers, you can do a standard phaco done very carefully in expert hands. You can put the lens in the bag even without support. So you have to make sure that you don't extend whatever zonular weakness that has happened, and make sure that you put the lens in there. So subluxations that are less than 6 clock covers, or 6 or less clock covers, you will have to support the bag. You will have to support the lens bag. You will have to either put a CTR or a Sioni ring. Then you can put the lens into the bag itself. If the subluxation is more than 6, that means you cannot support. You cannot support with a CTR. So that means more than 180 degree subluxation, zonular weakness. You don't try to even attempt CTR. You will have to remove the lens with the bag and then plan for a secondary lens implantation. All these phases, remember, if the vitreous is prolapsing, make sure that you remove the vitreous, otherwise the lens is going to I'm going to skip this video because of time. So this shows how the CTR should be inserted. There's 2 ways actually, hand on hand and fishtailing. Just read up on it. Surgeons who are doing this, how to insert a CTR, it's a nice video as well, but due to time I'm going to just skip it. So how do you fix the lens? We used to fix lenses with the scleral fixing lenses. This used to be what we used to do, maybe about Lalanta myself. We used to do this about 15 years back. But with time, we found, now this used to be like the gold standard. You used to do proline suturing, but after 10 years or 15 years, even the proline gets dissolved. That's what happens. We think that these are non-absorbable sutures, but they weaken. So we have had suture lenses which are fixed about 20 years ago. The proline gradually dissolves and then it may sublux. So scleral fixed lenses are no longer, that is not the way that we do these things now. Anterior chamber lenses, ACIOLs and iris claw lenses they are in the market. It's easier to put, but because of the obvious complications of chronic uveitis, and displacement and endothelial decompensations that can happen, these are also not our first choice. So the current choice is usually the scleral fixed tucked IOL, or what we call the glued IOL, and this is our preferred method as well. I'm just going to show you what we do here. We got, I think one slide is missing. So I'm just going to explain to you while the video is playing. So what we do in tucked IOL is basically we have to use a 3-piece IOL, and then the 3-piece IOL we will be planning to externalize the haptics, the PMMA haptics, and make sure that these are externalized and fixed. So you have to make sure that you have the anterior chamber and the anterior vitreous completely removed. Usually you need to take about 2 millimeters, 1.5 to 2 millimeter distance from the limbus, and you have to, with a 27 gauge or a 26 gauge needle, you have to make a tunnel which is again about 2 to 3 millimeters long along the tunnel, and you make the tunnel and go in and keep the needle inside. Okay, so that's the one. So important things are 2 millimeters away from the limbus, 2 millimeter length tunnel, and you go at a slant of about 15 to 20 degrees. So not more than 20 degrees, because if you go more than 20 degrees, you are going to tilt the lens, as well as the tunnel is going to be too short. So there are different ways of externalizing the haptic. This is called, one way is you have to railroad the haptic into the tunnel. So what I do is I get my assistant to dial the lens in while I hold the needle and the cartridge. You can do other ways as well. You can just put the lens into the anterior chamber and use your instruments to put it in. It doesn't matter. The principle is basically to make sure that you get the haptic out into the basically externalize the haptic like that. So these are like, you're on pins when this happens. You know that, things can happen. This can go down. It has happened as well. So once you bring it out, you externalize the haptic. You make sure that you catch it. And then you can use either an electric or a hot point to cauterize the tip. Make sure that you make a bubble so that when you push it in, it will stay in. So I will move it forward a little bit. So that's there. Then the other side, 180 degrees, similar way. You make sure you go in. Then you use the end-gripping forceps, the handshake technique, to make sure that you catch the haptic properly at a comfortable angle that you're there, and basically hold the haptic like that and railroad it out. Again, use the hot point to make a small bubble, push it in. You don't need to put any sutures. Make sure that it's all the way tucked in the scleral. They just need to use the conjunctiva, put it over this thing, and that's it. And the lens usually centers very well, and it's very stable. If you make sure that you get the correct plane, you have nothing to worry. So this is a good technique, and more surgeons are using it. I'm sure you guys also need to start learning this. This is something that you need to have learn as an anterior or a posterior segment surgeon. It's well centered, and the visual acuity is brilliant. So just closing up, immediate close-stop care. Make sure that you prevent infection, control the IOP, IOL centration, and IOP monitoring. Later on, you can have the problems in the back. Make sure that those are attended to. Finally, just want to tell you, you have to treat the overall patient properly. Don't rush into surgery when it comes to the lens. Make sure the eye globe is intact. Make sure the patient is better. When it comes to the lens, we plan it and decide on the time. Explain the patient to the patient. Don't give unrealistic expectations. They will always think this is another cataract surgery, and make sure that the future complications are attended to. Thank you very much.
Thank you, sir, for that informative talk on managing traumatic subluxated lenses. Your guidance has given us a clear understanding of this challenging condition. And this wraps up our first set of talks. So we'll be moving on to the Q&A session. And now it's your chance to ask away any question from our experts regarding today's topics.
Yeah, can I ask from Ella, sir, have you come across any eye problems when you are in the casualty? What would be the things that you would advise for a A&E doctor to the eye people? I'm asking the reverse basically. For people who are in the A&E, how will they manage the ocular injuries? How will they be referring the patients? Yes, to the eye clinic, or what should they be doing? Or
provided that there are no life-threatening problems to deal with, that want to make sure that that is everything, the summary of my talk also, and provided that quite happy, then they should get the eye specialist in that hospital.
so what would you expect from the casualty eye doctor when he comes to the A&E?
Anyway, he needs to assess, hopefully that he has been properly trained to make a proper assessment. That's number one. Then if he cannot deal with that particular problem, he wants to get the seniors to look after that. That is how it should go. And so it is the system which is available to deal with that problem.
Have you had any problems in managing that kind of patients and situations where the eye people or the eye doctors or eye casualty were involved, difficulties in getting help or anything like that?
Recently not. And during the wartime, I think there were so many complex injuries which were difficult to answer.
Nirodha, anything you want to ask? Medhavini, anything? Anyone from the audience? Yes. No. I don't. Question is on do you adjust the lens power? No. Usually, I try to keep it. We are trying to keep it at the lens plane itself. We are trying to get the lens into the anatomical position itself. So go with the normal biometry. My standard for a normal phaco would be leaving the patient emetropic. In this case, I would try to keep the patient about minus 0.25 to minus 0.5. Target is, that's it. So those measurements are important. That is the importance of the measurements. You stick to the measurements and the angulation so that eventually you will get the lens in the anatomical position. So that's why it's better to do the measurements and make sure that you direct the needle at the correct angle.
My question is
another question.
Yeah, my question is to Dr. Medhavani. Can you explain the slip knot again, please?
What you do is, so the throws, you do 2 throws, so that the 2 throws doesn't lock the suture. So you leave it with long ends with just 2 throws, and then at the end of the surgery you can lock it with another throw. So the 2 throws, how you do it is, when you have the forceps where you are putting the throw over, you follow the same one for both throws. So if you're going over the forceps, if that's what you normally do, you put the suture with the needle end over the forceps, and then you grab the end. So that's your first throw. The second one also, you keep the end free end on the same side of the knot, so that you don't need to rotate the forceps to find the end. Just keep the end on the same side of the suture, go the same way. So you have the forceps there, go over exactly the same way, and then you grab the free end and pull through. Now, so the suture is not locked. You can try it. The knot just slides pen down the free end, and you can easily adjust the tension. And also, unlike the 2-1-1, it doesn't open up. So it holds where you place it. So till the end of the surgery, it just remains like that. It's very useful for DALCs and PKs as well, because it loosens by itself, and fixes at the right tension. So you don't have to bother about adjusting or manually gauging the tension. It just opens up to where it's comfortable and stays there. So at the end of the at the end, when you've done all of the knots in a trauma, you've left the free ends along. You just put in the locking knot in. The other advantage of the slip knot is that the knot is really small, so rotating it is also very easy.
Thank you.
Medhavani, Nirodha. Now actually most of our lids are being sutured by very young emerging surgeons. So what are your sort of practical pearls for them to master the techniques?
So always know the anatomy, that's the main thing. And as I said, when I was in my second and third year in training, and then when I was a senior registrar, most of the times when I get calls, it's mainly the first thing a registrar would say, Aki, there's a patient, seems like there's tissue loss, as I said even before. Most of the times it's very hard to lose tissue around the eye. It's going to kind of hang on to that area. So go by the lash line, find where the lashes are, so then you can see where the things are approximating. So use some warm saline with a cotton tip. Use cotton tips. Cotton tips are very useful in lid surgery. So you can easily kind of scrape off the debris and find the lash line and go by the lash line. If the lashes are sitting in proper position, then you've done a good job.
So has described some Foley catheter technique in prevention of neck bleeding. Can you describe that, sir?
Yeah. When there is a penetrating injury, you have a small hole, and whatever the vessel is bleeding. Sometimes until you get into the theatre where you do the definitive surgery, stop that is very difficult sometimes with the finger, or the pressure is applied there. Just put a Foley catheter and inflate the balloon. If still bleeding, put the second one and inflate the balloon. You can go on like that. You can't do 100 or so. And there should be 1 or 2. But then there is a gap on the skin. Try and suture that around the tube. And that will look after, until such a time you get into the theatre and open it and give a GA. Foley catheters have been used other places as well. Even the liver, we can do Foley catheters and the balloon catheters to stop bleeding.
So what is the gauge you use? What is the gauge of the Foley?
Gauge, usual size would do. And largest balloon is the good. Actually, if you can't get that one, you could put the second one.
My question to Dr. Nirodha. After canonical repair, some patients coming without the tube in 2 weeks' time. At that case, what we have to do we have to re-explore the site and reinsert the tube, or leave it alone?
You can probe and syringe first. Syringe and see. Syringing is a technique where we can find so many things. We can get a lot of ideas about the canalicular system. So you can, with the syringing probe, you can go through the canaliculus and see whether you can feel the soft stop or the hard stop. If it's the hard stop, if it has done its job, then it's fine. Leave it be. You can use a topical steroid maybe, and that's it. If not, then we'll have to probe in the theatre. We'll have to probe and see. Probe, and if there's an obstruction, no point of putting a stent again. You can probe and see, probe and give some topical steroids. And if the probe is not going to work, then we can go for a secondary stenting if needed be. But the chance that it's going to work is quite low because it's a very small tube. Once it's constricted, it's going to stay constricted. So then the other option is DCR, or if it comes to a level, then we'll have to do a Lesser Jones tube. So syringe and see, if not probe. Probing is a good method. Nylon can cheese wire. Nylon doesn't do the job. It has to be a very smooth surfaced and it has to be a particular diameter. So either the DCR tube, we can, back in the days with the pigtail, we can introduce the nylon, and through the nylon we can guide the DCR tube into the canaliculus and tie it in a loop. That's what we used to do. But we don't use the pigtail anymore because we are damaging the upper canaliculus as well. The chance is if the lower canaliculus, because it doesn't work, then the patient is left with at least upper canaliculus. So nylon sutures, we used to use it if there's nothing, but better to use the proper thing. Otherwise, it can cheese via the whole system and it can scar up the whole thing. If we have a stent, best is to repair it properly. We have limitations in Sri Lanka, that's the only thing. I would at least put a yellow cannula and repair it accordingly. Yellow cannula, if you can put it in there, you can put a suture through it at the cut end and anchor it. I've done one 2 weeks back. The cannula, the last time I saw him, the cannula is still there. At least if we can keep it there for like 6 weeks, that would do. So at least put a yellow cannula and repair, because we don't know what's going to happen in the future. If they damage the lower punctum, then that's it. They're going to end up with, because this is a small story. I usually take cabs because I don't drive much. There was this guy who was driving the cab one day, and he was, when I put the location as eye hospital, he was telling me, oh, are you working in eye hospital? I was like, I'm a doctor. And so he was then telling he's got continuous watery eye since childhood, because he had a trauma and it was not managed properly. I don't know what happened. He says that he couldn't complete his schooling properly because he used to get bullied a lot as a kid, because he's a guy crying all the time. So all the kids used to bully him, telling that he's like a girl, he's crying. And then he was asking whether there's anything that can be done, because now he can't drive even. Because of the watering, he can't see properly. So these are life-changing things. So we might think, oh, it's just a cannuliculus, what's going to happen? Let's just suture it up. It can be life-changing, especially in kids.
Yeah, good point. Don't give up on trauma. Do your best, because it definitely can be life-changing, and people can lose their jobs. It comes to compensation. These are huge matters. Yeah, so don't give up when a patient comes with trauma. Okay, I think we should wrap up. Yeah.
The College of Ophthalmologists and the Association of Vitreoretina Specialists would like to proudly recognize and appreciate our guest speaker, Dr. Ranjit Ellavala, for his immense contribution to the Symposium on Ocular Trauma. And to hand over a token of appreciation to him, I would like to invite Dr. Dayavansa and Dr. Ellavala to accept this token of appreciation. Hope you are refreshed. So we now move on to our next session, where we explore the posterior segment sequelae of blunt trauma. To lead this discussion, we have Dr. Lalantha Gurusinghe, consultant vitreoretinal surgeon from Colombo South Teaching Hospital, Kalubowila. Let's give a warm welcome to Dr. Gurusinghe.
Good morning. So we are going to cross the boundaries into the posterior segment. I'm going to talk about posterior segment sequelae of blunt trauma. Right. When you talk about eye injury, so there's a terminology how to classify eye injury. There's something called Birmingham Eye Trauma Terminology System, where they classified eye injury into basically two groups. Basically, you can classify it into closed globe injuries and open globe injuries. Closed globe injuries, you can get contusions or lamellar lacerations. Open globe injuries can be rupture or lacerations. Laceration can be again divided into penetrating, perforating, or intraocular foreign body. How does ocular trauma happen? What are the forces? Basically, ocular damage can be due to blunt trauma, can be due to direct impact or compression wave forces, reflected compression waves, or rebound compression waves. When you talk about ocular damage by blunt trauma, actually there's something called 7 ring of trauma. There are 7 distinct circumferentially oriented ocular tissue anterior to the equator, which are classically damaged following a blunt ocular trauma. The first one is sphincter pupillae. You know, when you examine a patient, you have to look for the pupillary margin, look for radial sphincter tears. Then you can have iris base disinsertion. The iris base damage, that's a disinsertion of iris root from the ciliary body, we call iridodialysis. So when you examine, if you see a D-shaped pupil, so that is a sign of iridodialysis. Then you can get damage into the trabecular meshwork. You can see tears and plaque at the point of rupture. Then you can get damage in the anterior ciliary body. We call it angle recession. there what happened, the tear between the superficial longitudinal fibers from the deep circular fibers. Then there are occasions you see separation of ciliary body muscle fibers, attachment to the scleral flare. We call it cycler dialysis cleft, where it's exposed the internal scleral wall into the anterior chamber. Then, as Aruna mentioned, the next is sonules, so you can get sonular dialysis. Then we come to the vitreous base, where you get the retinal dialysis. So these are the 7 rings of trauma. So just keep in mind. So when you talk about posterior segment sequelae of blunt trauma, basically we have, I have listed up certain complication of blunt trauma. The first one is a commotio retinae. I'll discuss one by one. Then you can get vitreous hemorrhage, traumatic macular halls, choroidal ruptures, choroidal hemorrhage, then retinal tears and detachment, vitreous-based disinsertion. There's a serious complication called traumatic chorioretinal disruption, traumatic optic neuropathy, and optic nerve avulsion. So these are the basically posterior segment sequelae of blunt trauma. So what is commotio retinae? I think most of you have seen when you examine a patient with blunt trauma, when you do the fundus examination, you might see this this type of whitish glistening lesions. This is called commotio retinae. This was first described by Berlin in 1873. And usually it's self-limited whitening of the neuroretinal tissues. You can have direct, that is the site of impact, or maybe indirect due to the shock wave traversing from the site of impact. Clinically, it's significant if the macula is involved, but if you have a temporal or infratemporal, if you have, in the peripheral involvement, usually it's not that significant. Usually the temporal and the infratemporal quadrant are more commonly affected. So what if you look at the pathology, what's happening in the nerve tissue when you have a retina, when you have a blunt trauma, you get disorganization of the photoreceptor layer, disruption of the photoreceptor outer segments, as well as cellular edema of the molars and ganglion cells. But sometimes you might get RP cell contusions, or with time the RP cells lose its pigment granules with photoreceptor cell lead to permanent visual losses. If you do a OCT in a patient with commotio retinae, you might see the increased reflectivity with thickened ellipsoid zone and disruption of the interdigitating zone. So those are the actually OCT finding of patients with commotio retinae. So clinical symptoms, again, you might get a transient decrease in visual acuity, but it resolves within a few weeks. You might get persistent visual scotomas in certain cases. If the peripheral retina is involved, it's asymptomatic or slightly, they might present with a slightly restricted visual field. Prognosis is usually good with at least partial visual recovery, and if RP is severely affected, then you will end up with poor visual outcome. Then traumatic vitreous hemorrhage, Dr. Kapil is going to talk about this, so I'm not going to discuss too much about this. But this accounts for majority of vitreous hemorrhage in children and adolescents. Usually it's 54 to 82% of all cases of vitreous hemorrhage in young people is trauma. It's due to the forceful destruction of the blood vessels in the posterior pole and anterior chamber. The problem is actually it shows a slow spontaneous clearance, usually about 1% per day. So it takes time to clear up. If you have a less dense vitreous hemorrhage, if the visual axis is clear, you can observe, but if there's an associated retinal detachment or lens dislocation, then you need surgical intervention to deal with that. Because if you leave a retinal detachment with vitreous hemorrhage, the problem is you will get a higher rate of PVR. So I think you have to intervene early. So otherwise, if you get a mild vitreous hemorrhage, you can just watch. Then the next one is a traumatic macular hall. It's about reported in 1.4% of closed globe injuries and about 0.15% of open globe injuries. Usually the population at risk is young males. The mean age is 15. You get a full thickness, sharply defined retinal defects that tend to be more eccentric and elliptical with irregular edges. I will tell you why it's that. So when you look at the pathophysiology, so usually in young people, they have a stronger posterior hyalid adhesion to the ILM. So even after the trauma, we know in elderly people, after trauma, we get the posterior vitreous detachment. But in young people, even after trauma, it's remain attached. So when you have a violent compression of the globe, it induces an outward expansion of the equator with flattening of the posterior sclera. So this change in the structure of the posterior pole produces a horizontal force that can split the layers of the retina. Then what happened? Once the pressure is released, there's a sudden retraction of the posterior pole. It's like a trampoline, right? Sudden release of the posterior pressure enhance the anterior posterior vitreous traction over the very thin macula. So all these variable vector forces acting over the macula result in a more irregular, almost always elliptical macular hall. So if you look at a idiopathic macular hall in an elderly patient, you might see a nice round shape, full thickness macular hall. But if you look at a traumatic macular hall, it's usually elliptical with irregular edges, right? So that is one way of differentiating it. And usually it's measures 100 to 500 microns, but have a thinner average retinal thickness with a large base diameter. Degree of visual dysfunction and the recovery actually depend on the photoreceptor damage and the RP level at the time of trauma. There are reports saying that there will be spontaneous resolution without surgical intervention with good visual recovery, but it's unpredictable. It can happen. So spontaneous resolution occurs in usually young. If you have a small defect like 100 to 200 microns, or if the posterior hyaloid is attached, or in the absence of epiretinal membrane. So time for spontaneous closure range from 1 week to 6 months. 55% of the resolution happen between the 3rd and 4th month follow-up. So if you get a young person with a macular hole, small macular hole, you don't need to rush for the surgery. You can just observe, and sometimes it might close spontaneously without any surgical intervention. But patients with associated choroidal rupture through the fovea, I mean, it's poor visual outcomes, right? Treatment of choice is you have to do the TPPV, ILM peel, and then ideally gas tamponade. But there are certain occasions we can't put gas, like in young children, we can't position, right? If the patient is severely ill, or maybe patient's physical state like very ill, unable to position, in that case we can use a silicone oil tamponading. So anatomical results are usually good, but functional outcomes may be modest. So you always don't get the best visual outcomes, even though you can anatomically close the macular hole. Then the next problem is a choroidal rupture. It's a serious complication of closed globe injury. What happens when you have blunt trauma? It put extreme stress on the Brooks membrane. It's less elastic and less tensile strength than the sclera, so it leads to fracture. So that is how you get the choroidal rupture. You can get direct rupture at the site of impact. Usually it's anterior and parallel to the ora serrata, but the indirect ruptures due to the transmitted forces is located in the posterior pole, usually temporal to the optic disc. More than 60% of the cases involve the macula. You can have single rupture, but about 25% might have multiple ruptures. So just examine carefully if you get a patient with blunt trauma. So you have to do a dilated fundus examination. So it's appear as a curvilinear, crescent-shaped, reddish or yellowish line, and usually it's concentric to the optic disc, right? So it's just somewhere here, is somewhere there. The widest at the center and is tapered at the end. And the rupture will evolve with time, so it's become a white streak with time with pigmented margins due to the RP hyperplasia. About 5 to 10% of choroidal rupture will develop secondary CNV. So that is the complication of choroidal rupture. Sometimes if you see a choroidal rupture temporal the macula, so it's away from the fovea macula, you might have good vision. But the problem is later they might get CNV. So you have to follow them up to find any signs of CNV later. So 5 to 10% of them will develop the CNV, and more than 80% of CNV will appear within the first year of after the trauma. And if the rupture is very close to the foveal avascular zone, it's larger than 400 microns, are more prone to get CNV. So what are the poor prognostic signs? If the macula is involved, or maybe patient present with submacular hemorrhage or intraretinal hemorrhage or lesion to the damage to the inner retinal layers, choroidal hemorrhages and late choroidal neovascularization. So those are the poor prognostic feature in choroidal rupture. Then the other, I don't know whether you have seen this type of picture. This is called vitreous disinsertion. So this is actually pathognomonic in ocular blunt trauma, but there is one condition which gives rise to spontaneous vitreous disinsertion. Anybody? In neurofibromatosis, that is the only cause which can give rise to spontaneous vitreous disinsertion. This is actually called kind of bucket handle appearance. You can see it's a kind of handle of the bucket, so it's called bucket handle appearance. If you see this is actually pathognomonic of blunt ocular trauma. But it may be isolated, but most of the time it can be associated with retinal dialysis, retinal tear, vitreous hemorrhage. So I think if you see something like this, you have to do a very thorough peripheral examination, right? You might miss a retinal dialysis. So basically you have to do an indentation and fundoscopy. Then we'll come into the traumatic retinal breaks and the retinal detachment. So actually trauma is responsible for about 10% of all cases of retinal detachment. Why do you get detachments? So the creation of, So creation of holes or tears secondary to the strong adhesion between the peripheral retina to the vitreous base, because we are mostly talking about the young people. So their vitreous is firmly attached to the ILM. So when you have a sudden force, so they can cause tears in the retina. So that's why they get these. There are different types of breaks can develop following the blunt trauma. The common one is the retinal dialysis. Then you can have equatorial breaks. Then you can have giant retinal tears and retinal detachment. So we'll discuss one by one. So what is retinal dialysis? In retinal dialysis, you get break at the ora serrata. So you know why is ora serrata, right? So the break is at the ora serrata. So anterior edge is at the ora and the posterior edge is attached to the vitreous base. So it accounts for 6 to 17% of the rhegmatogenous retinal detachments. Mostly it's unilateral, but there are certain occasions you see about 48% bilateral cases. What are the common place or the quadrants which involve dialysis? Any idea? This actually involves supranasal. If there's a blunt trauma, usually it's involves the supranasal quadrant, but there are occasions you get the inferatemporal quadrant as well. So these are the two quadrants, mostly they can develop dialysis. Mostly these people are asymptomatic because dialysis does not progress into RD rapidly because their vitreous is attached, right? Vitreous is attached. So the SRF does not progress suddenly. So it's slowly progressing. Sometimes there are a few studies shown that, this detachment they have detected after 1 year of blunt trauma because even I can remember when I do in the foreign training, there was one guy actually, he was maybe 16, schooling, doing A-levels actually. The parents' complaint was he was nicely doing his work, but now he's not, lack of attention to his work. So he just then taken the child to the opticians and he found out that this eye vision is gone. So then referred to our clinic and we found out that there was a retinal dialysis with the detachment. Now, when we take the history, he had a trauma a few years ago. It's like that. So it's slowly progressing and you might not notice unless you do a proper peripheral examination. So any blunt trauma, just don't, maybe SCH, patient present with the SCH, right? Blunt trauma and SCH, but you have to do a dilated fundoscopy because otherwise you are going to miss these things, right? So again, I need a thorough peripheral retinal examination. That is very important. So how do you treat retinal dialysis? If the dialysis with no SRF, you can treat with laser or cryopexy. But if you have evolved into a retinal detachment, the best treatment option is to do a scleral buckle because success rate is over close to 95%. So it's because usually these patients are young, lens is clear, and it's very difficult to induce the vitreous detachment in these people. And if you do a vitrectomy, they will end up with a PVR. So best thing is to do external surgery in this type of cases. So scleral buckle gives the promising results. There are instances if the dialysis involves the superior 8 quadrant, they have tried pneumoretinopexy very successfully. So these are the options available for retinal dialysis. Then equatorial breaks, less frequent, is due to the direct disruption at the point of scleral impact. Then this is the other biggest complications we see after blunt trauma is the giant retinal tear. So giant retinal tear is a tear involving more than 90% or more retinal circumference. So that is how you classified giant retinal tears. It's again classified into GRT with detachments, or without detachments, or with detachments. With detachment, again with a posterior flap, whole posterior flap, or inverted posterior flap, or maybe associated with posterior extension like radial tears at the tear margin. Here the problem is they are highly associated with proliferative vitreoretinopathy. So treatment of choice is a TPPV. I think you have to use most of the time silicone oil, but redetachment rates are very high, usually about 45% cases due to the PVR. So it's very difficult, during the surgery to unfold these flaps. So we had to use PFCL to unfold the flaps, and then slowly when you do the fluid exchange, sometimes the retina roll back. In that case, sometimes you have to do the PFCL silicone oil exchange. So it's a bit difficult surgery. And also, even though you do a good surgery and later you see post-op in few months, maybe you might see again a redetachment due to the PVR. So it's a bit challenging. This is another complications of blunt trauma. This is a bit of a severe complication we call traumatic chorioretinal disruption, or chorioretinitis scleropetoria, right? Sorry, scleropetoria, chorioretinitis scleropetoria. Scleropetoria is a full thickness rupture of the retina and the choroid due to the blunt or nearby trauma from a high velocity object. So what happens when you have a sudden force, it deform the sclera, cause chorioretinal layer to split. But this the sclera is bit elastic, so it can leave the sclera intact. So you get a chorioretinal layer rupture without scleral damage. So you have a closed globe. So you maintain the IOP, but the internal structures get damaged. So usually it can be due to the indirect or direct shock wave forces, right? When you examine the fundus, you might see subretinal hemorrhage, vitreous hemorrhage, then the bare sclera, because chorioretinal layer ruptures and you leave the bare sclera. So you can see the bare sclera. And macular edema, choroidal breaks, disc edema, those are common presentations. But what happened later, it tend to fibrose. So therefore, and fibrose and scar formation, therefore the retinal detachments are not very common in this type of injury. You can get it, but it's less common. Now in this picture you can see here, you can see this scar here. So it's a completely retina and the choroid get disrupted, leaving the bare sclera, but later get fibrosed. So retina is not detached. It's called chorioretinitis scleropetoria. Again, prognosis depends on type of injury, object of injury, location of primary penetrations, maybe primary penetrations or location of rupture. So, there's a study called Ludwig study. Actually, they have graded the visual prognosis based on certain criteria. If you injury with a lower muscle energy like a air gun, pellet, or paintball, the result in poor visual outcomes compared to a higher muscle like a bullet injury. Temporal and macular scleropetoria had a poor visual acuity and very less likely to achieve 20/20 vision. And if it's associated with macular hole or maculopathy, so increased risk of incomplete visual recovery. And if it's associated with the eyelid injury, usually carry a poor prognosis, possibly due to the more profound ocular injury. And sometimes you might see optic nerve avulsion with this condition, so because the trauma is a bit severe. Then the next problem is a traumatic optic neuropathy. It's actually ranged from simple contusion to complete optic nerve avulsion. Have you seen complete optic nerve avulsion? Right. You might see a hole in the place where the disc is, right? So I forgot to put a picture here, but I've seen that. So it's the indirect is the most common cause. It's due to a transmitted shock wave from an orbital infarct. So it affects the intracanalicular portion of the optic nerve. So it affects the optic nerve, intracanalicular portion of the optic nerve perfusion. But sometimes you get the direct trauma due to the penetrating injury or from a fractured orbit causing bony fragment pressing the optic nerve, or sometimes orbital hematoma causing compartment syndromes, and also optic nerve sheath hematoma, again directly compressing the optic nerve, can cause traumatic optic neuropathy. Optic nerve has a limited regenerating capacity, so it leads to rapid loss of retinal ganglion cell within 2 weeks through apoptosis. So what are the signs of traumatic optic neuropathies? You might have decreased visual acuity, decreased color vision, apparent fibular defects, visual field defects, and sometimes if the retrobulbar part is involved, so you might have normal optic disc appearance, but later you might see, after a few months, optic atrophy, paled optic disc. So like this, this picture. Right, how do you treat traumatic optic neuropathy? There are no hard pass and rule. There are few studies actually, but none of them have proven good benefits of treatment. But there are few options. First one is a corticosteroid, right? So this is there is an experimental evidence. There are few studies actually done to analyze the high dose corticosteroid. So they have found out that it exerts an antioxidant effects, prevent the further injury following traumatic optic neuropathy. Actually, they are talking about high dose of methylprednisolone, like 30 milligram per kilogram, maintained by a sustained dose of 5.4 milligram per kilogram per hour for 24 hours to 48 hours. And also it improved the microcirculation and post-injury histology and the functional outcomes. So improved with methylprednisolone dose of 15 to 30 milligram kilogram in animal models of spinal cord injury. So it's a bit helpful because even it reduces the edema. So if you look at the intracanalicular portion of the optic nerve, if you have a lot of edema, it will further compromise the perfusion. So if you can reduce edema, it will can survive to a certain extent. So that is the major. In addition to that, they again found out that the steroid reduces the vasospasm, edema, and the nerve cell damage. And so high dose corticosteroid seems to have more vital effect than low dose corticosteroid in interrupting inflammatory cascade leading to optic nerve edema. So that is the pro or positive thing for the steroid. But there's another study called CRASH study. Actually, it's called corticosteroid randomization after significant head injury. Study evaluated the effectiveness of safety of megadose steroid in patients with acute traumatic brain injury. So they assessed the head injury patients with brain, but they found out at 6-month follow-up, the risk of death was high in the steroid group. So actually, this traumatic optic neuropathy treatment trial also, they observed observations, corticosteroid, and surgical interventions. They found out at the end of the day, the outcomes are more or less similar. But when a patient comes, we have to do something, right? Which all depend on the patient's extent of injury. If the patient has severe injury, I don't think giving steroid is going to helpful, but in certain cases, it might help. And now they are talking about something else, erythropoietin. So this is actually latest thing about for the treatment of optic neuropathy, and so it's demonstrated protective effect of injured retinal ganglion cell by inhibiting this caspase 3 through activity. Studies reported positive neuroprotective capability and visual recovery in clinical traumatic optic neurotherapy with erythropoietin, both through intravenous or intravitreal routes. It's a cytokine hormone that promotes hematopoiesis. You know that it's important to generate the red blood cells, and it reduces apoptosis in neurons, provide protection in mechanical trauma, neuroinflammation, and retinal and cerebral ischemia, oxidative stress, and optic nerve injury. So, erythropoietin in studies showed that erythropoietin receptors is expressed in variety of different cells of CNS like neurons, astrocytes, and oligodendrocytes. And during hypoxia, the neural progenitor cells release erythropoietin and stimulating neurogenesis through the erythropoietin receptors. So, there's some something about this erythropoietin. Actually, there's a study called Traumatic Optic Neuropathy Trial 2, Study 2. Actually, they have calculated, they have studied 3 different doses of erythropoietin, like 900 international unit per kilogram body weight, then 1,800 international unit per kilogram body weight, and 3,600 international unit per kilogram body weight over 3 days. You have to give in a IV infusion, like you take 200 milliliter of saline and dissolve in erythropoietin and give a slow IV infusion in divided, like you have to give it 3 days, right, at the time of injury, and after 1 month they have given the same dose, and they have found out there's no difference between the 3 dose regime, right? But there's another study. It shows actually corticosteroid and the erythropoietin group had a better visual outcome compared to observation. So, so you can decide whether you're going to treat or not, but we don't have 100% evidence at the moment to suggest that this treatment is best. But you can actually, something is better than nothing. So you can try if erythropoietin if it's available, or actually the other problem is that corticosteroid carry a lot of complications, right? Side effects. So you have to give high dose steroid. So erythropoietin would be a better option, right? So just keep in mind. If there's a compartment syndrome or optic nerve sheath compression, you can do the surgical decompression. But again, there's a study called this International Optic Nerve Trauma Study. They have found out surgical intervention was not shown to be beneficial over steroid observation. So basically, you come to the scoma. Basically, so there are options, but depending on the situation, you assess the patient's condition, and then you can offer treatment, either observation, you can give steroid or erythropoietin. Right. Then the last complications is traumatic scleral rupture. So Medhavani discuss about how to repair that. So I think trainees, you should know how to identify a globe rupture, right? So it can occur at the site of the impact, mostly due to the blunt trauma. So indirect rupture occur at the remote site. If phakic patients, pseudophakic patients, the most weak point is the limbus, right? And other patients, what is the weakest point? Is at the insertion of extraocular muscle. So you can get rupture. So if it's behind the insertion of extraocular muscle, sometimes you have to dissect them, remove the muscle, and you have to repair the scleral rupture. So what are the diagnostic signs of scleral rupture? Obviously reduced vision, that is the first one. Then the marked reduction of ductions. So the eye movement will be restricted. Then you will get a very boggy conjunctival chemosis with hemorrhage. You will find deep anterior chamber, severe vitreous hemorrhage, and a soft eye. So those are the findings of a globe rupture. So when you see a patient with blunt trauma or maybe penetrating trauma, you have to carefully examine patient, and don't put a lot of pressure on the eyelid, right? So it might expulse the content. So carefully examine the patient. Right. In summary, if you take the posterior segment injuries, the presence of coexisting lamellar laceration or suspicion of open globe injury, if there's no, then not associated with retinal breaks, not associated with retinal breaks or intravitreal intraretinal hemorrhage. You can do the medical treatment. Medical treatment is just give steroid to reduce the inflammation. If there's epithelial breach, you can give some antibiotics. So that is the medical therapy. If it's associated retinal breaks, no retinal detachment, we can do laser protocoagulations, observation, or retinal detachment, again surgical intervention. If it's associated with dense vitreous hemorrhage, so early surgical intervention if suspicion of retinal breaks, right? So we can't leave it there because patient will end up with a severe PVR and we might not be able to recover his vision. Yes, if there's a placeration of the globe or globe rupture, then you have to do the surgical exploration. So that is how you basically manage ocular trauma. So thank you. If there's any question, you can ask at the end of the session.
Thank you, sir, for that very informative talk on the posterior segment sequelae of blunt trauma. Now it is my pleasure to introduce our next speaker, Dr. Kapila Bandhu Tilaka, who will be discussing on managing traumatic vitreous hemorrhages and intraocular foreign bodies. Please join me in welcoming Dr. Kapila Bandhu Tilaka, Consultant Vitreoretinal Surgeon at National Eye Hospital.
Good morning. My topic is traumatic vitreous hemorrhage and intraocular foreign bodies, but actually there's no time to discuss two topics, so I thought of concentrating mainly on management of intraocular foreign bodies. When it comes to the intraocular foreign bodies, there are a lot of things to discuss, but the prognosis of the intraocular foreign bodies is very important because that's what the patient expects to, that's what you have to, at the end of the day, that is what you have to talk with the patient and others. So initial visual acuity, time of the initial other findings, especially the visual acuity and the findings on examination is very important. But there's a very important other fact is that actually the consultant JM, he will discuss about the medical legal aspects of this, because foreign bodies always there's an aspect of about 75% to 90%. There's a medical legal aspect. It may be some sort of assault or it may be a occupational injury. So because of that, when we are taking and documenting, very important to document all these things, including the finding at the point you see the patients. Because in some cases, one example is about some time back, we did one surgery for one patient who he was a very innocent looking, not with an innocent looking history, and we did a surgery of this particular patient. He told that he's a jeweler and he came with a boiler blast. He had one eye goes and one eye was NPL and the other eye was, we did the surgery in my unit. During the surgery, he was a goldsmith and he was handling gold particles. So we did the surgery. During the surgery, only one eye I was able to deliver. Lot of lead particles, lead foreign bodies. We were suspicious at that point, so we informed JMO and the police. That's how we were saved from consequences of this PASCO attack. Right? That's what happened at that point. So it's like that. Foreign bodies are very tricky. So when we are dealing with globe injuries, like Lalanta spoke with you all, about 30 to 40% of globe injuries we have to expect foreign bodies. So mode of damage of it is important. It may be what will happen with the foreign bodies. Sometimes it may be a direct impact. So we have seen that it can damage the cornea, it can damage the lens, vitreous and retina. It can introduce infections. Sometimes you have to expect reactions from the foreign body, and there may be a forced inflammation and things like that. And there's one point you are always missing is the sympathetic ophthalmia, because that point we are not considering, but we see some cases like that also. When it comes to the mechanical effects, sometimes the patient only live with mechanical effects. As example, sometimes they are working with the workers, the garages and things. They are working with very sterile things like grinding wheel and things. So when something come and go through the eye, these are sterile foreign bodies. They can cause only the inflammation. So we have to be careful. The foreign bodies give a different, the picture is completely different from each and every case. So the location of foreign body I am not going to discuss, but you see anterior chamber, the iris, posterior chamber. Iris, anterior chamber foreign body is not that commonly we see like just foreign body sitting in the anterior chamber, but sometimes we see after your repair, hair follicles and hair particles inside the anterior chamber. These are not the foreign body what I am talking. But sometimes the foreign bodies, usually they lie within iris because of the inflammation we can't see that much. And angle is the other common place. Then we have seen many foreign bodies inside the lens, anteriorly or posterior. Vitreous and the retinal foreign bodies will discuss. So what sort of reactions to the foreign body we are expecting? So the inorganic foreign bodies, sometimes there may be inert things like glasses, porcelain, gold, silver and things like that. Or sometimes you can some cause local irritative reaction. Because of that, you can get encapsulation. These foreign bodies will encapsulate. So sometimes we see cases encapsulated iron foreign bodies without any reaction after years. Then separative reactions we see with copper and some, and then specific reactions to some foreign bodies like iron. So siderosis bulbi is a very important thing that we have to concentrate on. So what will happen here when iron foreign bodies go on into the eye, other than the infection and inflammation itself, it can cause problems. So usually hydroxyl radicals and the free oxygen radicals can cause effects. So siderosis, when we are talking about the siderosis in iron toxicity, there is two types of siderosis. One thing is a direct. Direct means that these radicals release and cause direct damage to the pigmentary epithelial structures mainly. The other one is indirect siderosis. You might have heard or not heard, but indirect siderosis, that's where sometimes you see after the siderosis picture like a RP, retinitis pigmentosa. Here what happens is, these will damage the microvessel. So it's like a microangiopathy which can cause the damage. So that picture also we see. So clinical manifestations like anterior epithelial capsular lens involved, we see that deposits and greenish and reddish brown pigments. Then when you examine the retina, you see the retinitis pigmentosa like appearance. When you do OCT, you see that inner segment atrophy. Then secondary open angle glaucoma, sometimes due to trabecular meshwork damage. So here you can see right side, you can see the deposit on the endothelium. Then lower picture you can see, I don't know whether you can see that pigments on the lens. Then you can see the difference there. So you can see a heterochromia. Because of that, you can see now left eye is the affected eye. You can see a little bit more brownish, while right eye is the normal eye. So ERG is also important. I am going to highlight few points. I can't talk all about the foreign bodies. So ERG is also very important in management of foreign bodies, especially iron. When are we going to do ERGs? Sometimes some patients come after about 1 year, 2 years with features of siderosis. These patients, very, very important to do the ERG because we need a baseline. So, sometimes we have, after removing, who are having some sort of a siderosis, we remove the foreign body, then we have to see the recovery. So we can do ERGs in intervals. So when we talk about the ERG, the main problem we see in the B wave, but at the first maybe instance of early predictors like reduced oscillatory potentials, which we see in these cases. So other one is a chalcosis. Chalcosis, always we talk about the copper foreign bodies. Now copper foreign bodies, as previously, now we are talking about this particular component, what sort of reaction cause. So when it comes to the chalcosis, do you think like all copper foreign bodies, will they cause chalcosis? it's a different, right? If it is a copper content is more than 80%, because we usually see, visually we won't see pure copper, we see some sort of alloy. So if the copper component is more than 85%, we see very bad reaction, almost endophthalmitis, violent endophthalmitis reaction. That's why we ask, that's the history is important, so we have to take it out very quickly. If it is between 85% to 70% roughly, the copper content, then we see what is called calcosis. If it is less than 70, usually it is a little bit, you don't see this type of reactions. So that's like, so all the copper foreign bodies won't cause calcosis. So clinical manifestations, you know that KF rings, what we see in some other diseases, sunflower cataracts, golden in color, then we see a retinal deposits, degenerative retinopathy-like features. So these are the KF rings. Sometimes you receive patient from neurology also to see the KF rings. So you have to see the blue light with the descendant membrane, which you can see this copper deposits. So other thing is a sympathetic ophthalmia. Always we think that sympathetic ophthalmia is not that common, but to a certain degree it is common. Don't forget that, because that's in trauma cases, sometimes we concentrate on other things, maybe infection and other things, and we lose this factor. That's why sometimes I ask you to start steroid in some suspicious cases. So what are the things we have to, so seriously, this is a bilateral granulomatous reaction we see, but we have to differentiate this from other reactions as well. So this sometimes, when it is the sympathetic ophthalmia starts, usually it affects the other eye as well. So there are some predisposing factors that we should know. It is usually penetrating wound. Usually wound in ciliary body area, they have shown that it is more common, this type of sympathetic ophthalmia. More common in children than in adults. So sometimes we like a proliferative pigmental epithelium nodules like features like also in these type of cases, but usually it is very difficult to see affected eye because eye is inflamed. So clinically, we know that the affected eye, we know that normal features of sympathetic ophthalmia we know, but here we have to concentrate on the sympathizing eye. The other eye, usually we see 4 to 8 weeks, sometimes we see, maybe after 2 years. But usually what we are missing is 4 to 8 weeks one. So this one, now if one eye is affected while the other eye is red and looks like little bit red, inflamed, patient complain of photophobia and other things, don't think that it is conjunctivitis. So we have to consider whether we have to review our diagnosis. So treatment, actually we don't have, at the prophylaxis we don't have anything other than meticulous repair. Here you can see a down one. This is a repaired scleral rupture, but you can see that the test there, while you are repairing, you have some sort of ciliary body and choroid is coming out through that, which also not properly cleaned or separated. So these type of cases, they have shown that sympathetic ophthalmia is more common. When that is the thing. So the prophylaxis is like that, proper repair. Then when you see that we have to start corticosteroid, you have to start corticosteroid proper dose, not a pediatric dose for an adult, because that won't cause, that will you just reduce the course of the disease temporary. So you have to give them proper corticosteroid dose and if necessary immunosuppression. Most of the cases require immunosuppression. Then only we can control and we can save the other eye. So from there, we will just move, we have time for evaluation of the foreign body. How are we going to evaluate this patient? So we were talking about the history and the other things. Then the ocular examination, always visual acuity is very important because you have to document it. Then the pupil examination, there's a medical legal aspect for that also, because sometimes I have been to the courts in several occasions, because sometimes other lawyers will ask you whether this has happened after your surgery. So we have to document it. Because these surgeries are not simple surgeries. It's a very complicated surgery. So the other party can argue that the patient, this is not due to the primary injury, but this is after our medical intervention. So we have to document all these things. So the slit lamp examination and other things is very important. And the other thing is globe rupture. Now when we are suspecting, now some patients comes without even, we can't see any globe rupture. We just see some redness in the conjunctiva or somewhere. And we have seen many cases like that with a foreign body siderosis after 2-3 years, which was missed at one point because history has not, they have not taken proper history. The foreign body, sterile foreign body has gone through the sclera. Somebody has treated as conjunctivitis because it was a sterile foreign body, no inflammation, no infection. So imagine, we know that X-ray, ultrasound, UBM, CT, and the MRI plays a big role. X-ray, still sometimes some places we do because it is low cost and we have access. So we can sometimes directly localize. I'm not going to discuss all these things. You know that it's a very simply everybody knows. So we can take 2 sites and then we can compare and we can even localize where the foreign body is. Ultrasound is very important because it is non-invasive, inexpensive, easily performed and 98% sensitive in detecting foreign bodies, including vegetative and iron foreign bodies. So it's like when we do the ultrasound, you know that we can see a steeply rising wide echo spike in these cases, and even with the reflectivity, sometimes you can decide the components, composition of the foreign body. And sometimes it helps us to decide the distance. So like ultrasound, A scan. And when it comes to B scan, it is also very helpful. Why? Because we know that it is what sort of like acoustically opaque foreign bodies, almost all acoustically opaque, so you can identify that. Even low decibels, we can find them, and you can localize the intraocular foreign body. And other thing is now, like where it is, other thing is very important to identify whether this foreign body is like sometimes what sort of a mobility foreign body, because now if it is stuck in the retina, it is not mobile, while if it is in the vitreous, it is mobile. So like that we can plan our surgery. And in addition to that, this ultra B scan is very important to identify the associated damage. Some foreign bodies you can see that vitreous hemorrhage, suprachoroidal hemorrhage, retinal detachment, choroidal detachment. These points, these things are very important because we can document them. Then it's very important for management and the plan of surgery and even a prognosis. So in this case, you can see ultrasound. You can see that arrow shows the now foreign body, which is just above the retina. It is not attached to the retina. And you can see the spike pattern as well. The other one, now what's the difference here? You can see that foreign body. So these foreign bodies, actually when you see a foreign body, no point in doing a static one. Static one means you take a picture and analyzing it like this. Actually we have to do a dynamic one. That means that you have to do it yourself. So then you can see that it is now attached to the retina. So we can plan. Now here you can see that anterior foreign body. You can see that spike. First spike is due to the lens. Then second you can see just behind the lens there's another foreign body, while other areas looks good. So you can happily proceed with the surgery. So this can play a big role in planning of these surgeries. When it comes to the anterior segment foreign bodies, sometimes anterior segment foreign bodies are difficult to identify. Sometimes we can't see them. Why? Because sometimes we suspect a foreign body in the angle, but we can't do a gonio these days because of the recently repaired corneal laceration. These cases, we have to go for optical coherence tomography, where we can identify foreign bodies like that. You might not have seen, but it's very. So ultrasound biomicroscopy 50 megahertz one is sometimes very helpful to identify these type of foreign bodies. Now you can see this. This is in the iris. So vegetative foreign bodies, like small parts of the tree parts, very difficult to identify because of the color and other things. So UBM is very helpful in these type of cases. So CT, always we do. You know that it is high sensitive, can accurately localize. But sometimes it is not possible to localize accurately because of the high reflectivity of these iron foreign bodies. So sometimes it's not sure. Sometimes radiologist says that it is foreign body is outside the sclera. So your clinical judgment, then when you bring the patient, you say, come and tell me that it is outside the globe. But clinically I assess and do the ultrasound, which is very sensitive, and we decide no, it is inside, and most of the time our diagnosis is correct. Because radiologists depend on the radiological findings. These patients, we don't need that much cooperation. For children also we can easily do. Does not cause, we don't have to manipulate the globe like B scan in some situations, in ruptured globes. Then sometimes we can predict the composition. The protocol is like we can go for several protocols, but 1.5 millimeter cuts we have to request. Then the usually CTs can't identify less than 0.7 millimeter size ones, but steel and copper 0.06 millimeter up to 0.6 millimeter they can identify. Aluminium and glasses 1.5 to 1.8. These cases sometimes CT is not that useful. Wood, if it is very small, sometimes we can miss. So MRI, don't think MRI is contraindicated in foreign bodies. No. It is sometimes it is very helpful because some cases we know that there is a foreign body, looks like there is a foreign body, there is inflammation. Still, we can't see it. We do X-ray, CT, everything, but there's so we can exclude iron foreign body most of the cases. Then we have to think about the MRI in some cases, but you have to go through thoroughly and you have to decide. So I don't think I have a time to discuss management. So you know that management is the same, but I want to discuss about the timing, advantages of the early timing, and there are some disadvantages of the early timing. Early timing reduces the risk of endophthalmitis. Then the PVR, if it is like a retina detachment, and it's a single procedure for the patient. But at the same time, delayed removal has certain advantages. You can control the inflammation, right? You can control sometimes infection. And at the same time, you know that when you are doing the surgery, if there's a posterior vitreous detachment, then little bit supportive for the surgery, for a retinal surgery. So because of that, that is important. And at the same time, sometimes you bring a patient almost like infected and looks infected, so we are doing in a casualty theater. Facilities are not adequate. So in these cases, if we delay a little bit, we can control the infection and inflammation, and we can go to a proper theater. So considering all this, timing is very important. So other features, things like endophthalmitis and other things are very important in management of foreign bodies. The time is over. Okay, thank you very much.
Thank you, sir, for the comprehensive presentation on intraocular foreign bodies and how to manage them. Ocular trauma is not just about clinical management. Medico-legal aspects also play a key role. So to discuss this, I would like to invite our next guest speaker, Dr. Ramesh Alagiyawanna, Consultant JMO from Colombo North Teaching Hospital, Ragama.
Okay, thank you, Dr. Dayavansha, for giving this opportunity to give this type of lecture. To that, I know these are most juniors, those who are budding consultants, okay, and MOs. Anyhow, that until coming to here, I also thought I have some knowledge about ocular trauma. So I was lucky to observe these presentations. So that before that I learned when I was in medical school something about ocular trauma. Then while doing postgraduate period, I had 2 weeks appointments in ocular trauma. Anyway, that knowledge I am using when I give evidence to the courts. So defense lawyers are not arguing with us. So until that, evidences are not challenged in the courts. When one has opportunity to challenge, has to be taken as admitted. So when we go to courts, we are giving our opinion regarding these injuries. The defense have their power to challenge that opinion because we are not consultants. So here one judgment given not regarding ocular trauma to every aspect of this evidence giving in the courts. So until not challenged, we are okay, you are safe. They can ask eye surgeon to come and give evidence in the courts. Okay. So when we are talking about ocular trauma, first we have to see what are these legal background, what are the performance we are doing. One is this, you have seen in that big paper connecting to bedhead ticket, that is called MLEF, that is issued by police. They issued that police to do that basic legal actions. When we see the medical legal examination form, we are looking at injuries, what are the types of injuries that is matching to even when we talking about eye injuries. That is not basic injury type. We have another line called other type of injuries. We are writing that other type of injuries, like not like just laceration, corneal laceration is different. So we are writing that one, that is more severe than normal lacerations. Then we have to think what is the amount of damage suffered to the victim. In that case, we are going to MLR. There is a part, when you see MLR, you can get that MLR is a health form, medical legal examination form is that 1135 is the health form number given. When you go to the last page of the medical legal report form, you can see there are 8 limbs. From these 8 limbs, we are deciding whether that injury is grievous, barapatala or not. When we see there, you have that number B, permanent privation or impairment of sight of either eye. That is beyond our normal knowledge. That part we have to get from your side. That is why we are going through the bedhead ticket. We are expecting to see whether that injury can cause injury or direct complication of injury. For example, fibrosis, corneal laceration, then fibrosis. Not remote possibilities like after infection, something is going, some long complications. So that can cause whether permanent privation or impairment of sight of either ear. So we want your opinion from there. That is why when something you are not having very clear understanding, if you don't know, we don't know anything. So when that one go to the courts, benefit of doubt is going to the defense side, those who did the assault. So that case is going towards their side, then punishments are less. So that is why we want more clear opinion from your side. Then when you go through this some more, you can see number F, permanent disfiguration of head or face. Eye is very important side to see disfiguration. You have discussed that we can get your opinion, whether that is permanent or partial. That is also very important. If that is permanent, we can give our opinion to police to proceed. Then last one is here, number I. There, whether that because of injury, whether that person is unable to do their normal day-to-day work for more than 20 days. That is why usually after discharge, you ask patient to come after 3 weeks. So same time, we request patient to come and see us. So 21 days, no problem. If more than 21 days, patient is not able to do their normal day-to-day work, then we can put this one as grievous hurt. So that is necessary at the initial stage of management in the case of medical legal aspect. So that is why we want your help. So when we have court attendance, sometimes we may need medical legal doctors going to courts, or sometimes your side has to come to the court and give evidence. As I said, if until they are not challenging, we can take your burden and we can give evidence. In such case, sometimes you are getting to see a patient through magistrate court order. If that is coming straight to you, you have to give the report. Then your direct involvement in this case between you and the magistrate court. If not, this is considered as a teamwork. We are also in the same team. So BHT is the discussing medium. So when you are writing something, we are also writing that one. When we go to courts, when we give evidences in the courts, there is a rule. They are telling hearsay evidences have no value. What is hearsay evidences? We don't have direct involvement. We are looking from somewhere. We are hearing from somewhere. Has no value. So that particular party should go and give the evidence. But when come to as a team, we are in a team. So we are delivering your opinion through JMO. So as a team, then that is not considered as hearsay evidences. So we are in a part of your team, we are giving the evidence to the courts. That is not applied when that is straight away coming to your side from the magistrate court. So that is why some consultants, they like to get their involvement through JMO's office. Okay? Then when we go to the private sector, we know we are not a team, except in a case of private hospital. When somebody admit to the hospital, they refer to a JMO. Then we are in a team. Otherwise, if you are channeling a patient with eye injuries, then you are direct involvement with the patient. No other team is involving. When you are having a GP practice in your place, that eye injuries are coming to your place, you are direct involvement. Your responsibility is to deliver your opinion to the courts, and you have to attend to the courts. Okay? Then, so I told that we don't have much knowledge about eye, that this is special aspect. So you are considered as experts. By the way, one is you have paper qualifications. Like eye consultant, they have postgraduate different exams and they have paper qualifications. Some of these doctors, they are not attending to getting paper qualifications, but they have experience. Sometimes consultant may have some difficult cases, about 20 cases handled by particular consultant. But sometimes some senior doctor, they may have 100 cases successful attending and experience. So that experience is considered as an expert while giving the evidence. They are asking whether you have paper qualifications, how is your experience? Both have same value. Then when we come to the unit, you have a unit with a consultant and registrars and MOs. That is a team. So under direct or indirect supervision from the consultant, you are giving your patient care. So consultant is getting main legal burden, but your side also you are getting some responsibility. They may ask you to come to give evidence in the courts, not only the consultant. Okay. So that injuries, I don't want to discuss this one. This is primary when compared to your knowledge. Different injuries, why that those injuries can cause visual impairment. Okay, when we move to those injury description, you have to have documentation. That is very, very important finding. Findings you have to write in the bed head ticket. Or if you are doing private practice, especially these eye injuries, you have to keep your records. That is important to divulge that information to the courts. They are expecting to keep records with you. That may be 10 years, 15 years. They are just taking, doctor, we don't want any legal involvement in this case, just treat me. But when they go, later they are going to police, they are complaining and they are telling, that particular doctor treated me. So then police is the one making that record and they are forwarding that record to the courts, so you may have to attend. So that once we are discussing this medical medical legal involvement in the case of medical negligence, we have one is medical negligence cases you are getting. Or then you may have to attend to workman compensation. When we come to medical negligence, I got some few of these cases. They are from a book. That book is special. That is written by a judge in India. That I got the book from a lawyer who is practicing in Sri Lanka. Lawyers have medical books. This is regarding medical negligence. What they do, that particular section, when we talking about eye, they have cases. Examples in India, what are the verdicts given? What they do in the courts, they are taking that particular case. According to this book that is practiced in India, the verdict is given like this. So they are trying to match cases, those which are in Sri Lanka. So I got few cases from there. Sorry, I am little bit deviating from main point that about this one, because little bit away from the ocular trauma. Some few cases there, some are directly regarding this ocular trauma. This is first case I found, real case in India. So that this teacher suffering from glaucoma in right eye, having 100% eyesight by using glasses. Then they approached an eye surgeon who conducted, because they are giving assurance, you don't want to put glasses, we will do, I don't know whether this surgery whether doing in Sri Lanka. Okay. So then they did this operation, and but not cured, did not get the eyesight correctly. So next operation they did to filter in the water. I don't know whether glaucoma that they are doing that filter in the water. So that was in the courts. Finally, courts given the verdict as failure to perform glaucoma test before operating for radial keratotomy was negligence. So this case, they are getting to our setup. Very easy. You have to perform other investigations and you have to find out what is there. If not, these problems can arise. Then this is related to ocular trauma. Here that India, they are giving lot of local medicines and different things. A patient suffering from pain in left eye as some foreign body fell on the eye, was given some subconjunctival injection. I don't know whether here you are giving, India they are giving, of antibiotics on the temporal region of the left eye unnecessarily, and was given some antibiotic eye drops and pain relievers, and resulting bleeding was not noticed by the doctor, and doctor has not advised patient for further treatment of the eye. Nor did he appraise of the seriousness of the limb, except giving prescription of some tablets and eye drops and advising bed rest. So this one also, they gave verdict as clear case of negligence by the doctor. When you do private practice, you can see some people coming with some problems of foreign body. You can just give eye drops and you can send the patient to there. So these are the problems. Verdict is there, they are applying to Sri Lanka. Okay, again a foreign body. So this one, grill bit has broken and came to right eye, got admitted to the hospital where eye surgeon examined him and advised that the iron piece fixed in his eye could be removed by operation. X-ray did not give any clear idea of existence of foreign body in the wall of the eyeball. Though surgery was no helpful, eye surgeon performed the surgery unsuccessfully, and piece was still in the eye after operation. We discussed this foreign body one, but you are doing lot of investigations. So they did that operation. State Commission held that performing the operation knowing that the location of foreign body was not indicated in the X-ray report amount to deficiency in service, medical negligence. Okay? I don't know how far this is applying to your practice. Okay. Next one. An MBBS doctor who is not eye specialist, some MOs are doing, gave medicine to a patient who approached with a foreign element and pus in the eye. He did not contact any other eye specialist, kept the patient on medicine and bandage for 3 days. I don't know, you are not putting bandaging for this one. India, they do. Okay. When the bandage was removed, the patient was not in a position to see. He went to another hospital where he was told that he lost his vision due to wrong treatment of his eye. So that went to the courts. Then, so they decide doctor did not discharge his responsibility of due care and proper treatment and was guilty of deficiency of service. That is, they have to get you compensation. Next one. Again, that is little bit deviating from first that ocular trauma. The patient was diagnosed to be having glaucoma in both eyes, and he was operated on an assurance that his vision would improve. The patient continued checkups and took the required medicines that there was no improvement. The doctor performed cataract operation later, but still no improvement. An expert opened that the retina of the eye was weakened. the doctor plead that the patient might have loss of vision due to glaucoma. There are a lot of things. If the patient had lost his sight due to glaucoma, there was no reason for him to operate for cataract subsequently. The National Commission held that eye surgeon failed to explain the reason why the patient was lost his eyesight and held him guilty of negligence. It applied the principle of res ipsa loquitur. What is that? That is itself, that is proving that this is negligence. They have to explain that is not negligence. I don't know this one, but I have seen several cases. They do cataract surgeries, and once death happen, when we do the brain dissection, I have seen lot of cases, occipital lobe infarctions. I have personally seen lot of cases. Lucky they are not going, we are not divulging the information. Okay, this is the last one. Operating diabetic patient without oxygen facility. When you have eye surgeries, I don't know whether in the hospital, you are in private sector, how is there, whether they have those facilities. Where a patient with no history of diabetes and asthma was operated for cataract in hospital, not having any facility for administrating oxygen treatment. Patient became unconscious for want of oxygen, necessitating shifting him to another hospital where he died. The hospital was held liable for deficiency in service. That's hospital, vicarious liability, that is called. Okay, that is not the doctor, that hospital, but doctors are operating, doctors know that the hospital doesn't have oxygen facility, then that part indirectly coming to doctor even. Okay, some cases, patient's negligence, that is not doctor's negligence. Where an operation for cataract, intraocular lens was implanted, but the patient did not turn up treatments and it was not shown that the procedure followed by the doctor was wrong. Some patients, they don't follow that other procedures. So then once they lose their vision, that is not doctors, that in India there are these proven cases. Then patient's left eye was operated upon by the eye surgeon and lost his vision. The State Commission held that there was no negligence as he examined the patient 3 times and conducted several pre-operative investigations. That is why we want that proper documentation. Incidence of expulsive hemorrhage that occurred to patient was rare and could be said to be 1 out of 1,000 cases of eye surgery. So that is no negligence. Okay. So those are few examples that I got from law book in Sri Lanka, those available with lawyers. Okay. So that is how they are taking you to the courts. Okay. So that is basically about this medical negligence. Then we have another one, workman compensation, that you have to attend. We can't go because we are not experts in giving. That compensation is something we are giving, that how much damage has happened, so that damage they have to pay the other party. Then while in the hospital stay, how many days in the hospital that other party should pay. Then what are the other treatment, drugs taken or some other expenses they have to pay. Then after that, how many days in the home without going to work, that is also a compensation. Then last part is how much visual impairment due to injury. So that part, that first, previously I told parts anybody can give, but that last part, how much is the visual impairment, that your expertise, you are the ones going to tell to the courts. That is why this is going not to magistrate court, this is not going to high court, this is going to district courts. District courts you have to attend once they give summons, but that is private, not legal, not completely legal. Legal, but that is private one. You can get some money, but you may have to attend to that one. If that is in the summons, they are telling, if you are not getting enough your amount, your expenses, you may not able to attend to the courts. So you can write to the courts that this much they are not paying, so that we can't go and come and tell, because you can't get leave from the government sector for these private things. Okay. So that workman compensation earlier, this was the earlier circular. I think you can see that eye injuries, total loss of sight of both eyes, that earlier that was considered as 100%, even now also considered as 100%. Then total loss of vision in one eye, earlier circular workman compensation, they considered 50% loss of earning capacity. Now 2022, they amended that previous circular, one eye, that one changed to 80%, not 50%. That is more compared to earlier. So anyhow, that you may have to attend to that one, and you have to give. Sometimes that impairment is less. That maximum you can give 100, maximum you can give 80. Below that depends on your opinion. Nobody can challenge with eye surgeons. So you can decide the amount of loss. Now the problem is, some patients, they are coming to us after trauma, they are telling they can't see. That is the other biggest issue. They can't see. When we refer to eye surgeons in local hospital, I can remember earlier when I was in Watupitiwala, I can remember patient told, can't see. They look through whatever the facilities available with them, nothing was there. But still patient was telling can't see. So what we do, they have to refer to another specialized center. There are some other issues in the eye with the other investigations. So that is the problem in the courts. We can't give our opinion, just what they are telling they can't see, we can't put as grievous hurt, can't see. Then we have to refer to local, that particular our hospital consultant. When they look, they can't decide. Some cases, those are the issues. So when you go to periphery as a new consultant, you have to think about this one, that we don't know. That may be actual visual impairment, that may be they are trying to make as visual impairment. So that is the biggest issue in the field. Okay, thank you very much for listening this one. That if there are any questions, you can ask now. When I delivered this lecture with the eye surgeons, they asked a lot of questions.
Any questions you want to ask? Yeah.
One of our patients who working in a garment sector comes with some traumatic eye injuries with a corneal laceration and cataracted eye. Initially we have done the cataract repair, corneal laceration repair, and send patients to the Colombo vitreoretinal unit. And actually Dr. Dayavan sir has seen the patient and done the IOL implantation and TPPV. Later on, patient, the vision, best corrected vision is 636 and came us with 660 visions, almost same equal as the Colombo and our unit, demanding some compensation from the garment sector. I think sir has seen the patient, and given this injury was temporary vision loss. And patient came to Kuliapitiya and asking whether it is temporary vision loss or complete vision loss, whether
Okay.
permanent vision loss. So we are in dilemma. Patient, we have given the letter to user to decide whether re-evaluate this patient and give you a valid opinion regarding the event. So what is the 612? Uh-huh. Yeah. Definitely. So
there are two things, quantity and the quality. So after IOL, she's a young girl.
Yeah.
So that is actually after the IOL, we can say, so vision is improved to 6 to 8. That's a quantitatively it is a normal vision. But quality wise, actually we are not assessing the quality of the vision. So but actually we have no provision in the whatever the way quality of vision. We have to say go by the quantity. So it was improved to 6 to 8. And therefore now she can go back to work, but she wants to get the compensation from the company. She say I can't work. So
Yeah.
that's what I said.
So,
Somebody has permanent vision.
So my question is, what is the temporary vision loss and the complete vision loss? And what if it is a temporary vision loss, the compensation is given at 50 and 100. So you have said it is 80. In between, is there any percentage?
Now here that the problem is, one is that corneal laceration. Don't know whether that lens cataract is due to traumatic or that pre-existing cataract.
No,
that is
cataract. Traumatic
cataract. Anyhow, that according to compensation law, that what they are telling, that temporary period that he can't work. That period they have to give, there is a percentage from their salary they have to give. So after that, rest of the things, impairment, here not 100%, that they are telling one eye maximum you can give 80%. Depends on the job. That is also we have to consider. That garment worker working with machine, whether that person can't do that one. Depends on the job, whether that is permanent or not. So that then they have to find out another job. So that one we have to write in that place, because of that. According to that, this is the type of job that person is doing. So then that they can't do that work. So from there they are deciding the amount. That is deciding by that labor department judges, not us, that part. We have to divulge those informations. We can't decide everything.
Any questions to ask?
When I was working as a MOI in Dambulla, in triplet delivery, baby was diagnosed as an early ROP changes, retinopathy of prematurity, and we have sent the patient to nearest VR unit, Kandy. And they have seen the patient and asked the patient to come back in 2 weeks later. Then unfortunately patient unable to attend that clinic visit because of some fever or something, then admitted to Dambulla eye unit, not the Dambulla pediatric unit, with some infection, and they have not informed us regarding this ROP problem. Then 1 to 2 weeks later they have gone to the Kandy eye unit, but unfortunately that stage the ROP was untreatable stage, and they have transferred the patient to Colombo, and they have done PRP or some procedures, but finally patient ended up with blind both eyes. Then patient got for the court. Finally what was happened, the Kandy people, actually the Kandy nurses are not educated the patient regarding the importance of that. Missing the vision was unable to take, that was the decision.
Okay, that one I think they have taken from that book. I saw that one, I did not put because of that is not from this ocular trauma, that is why I did not put that one. Also in that book clearly mentioned that one, that we have to attend early, so that if you have documented that them to come this one at this particular time, if that is documented you are safe, otherwise they are taking lawyers. This according to Indian law this was happened, so that is negligence.
I think that's good you mentioned about this Indian book.
Yeah.
I think so. It's very important for the trainees and everyone to record the findings properly, because most of the time the court case come maybe 5-10 years later. You don't know, you can't remember what the patients, but when you go through the documents, nothing is there. And also don't do unnecessary intervention. For example, say if the patient has end-stage glaucoma and on 3 drugs, and a patient having cataracts, you without explaining the risk, don't do the cataracts, because you might end up with wipeout. So you'll fall in trouble. So these are the things important to remember. Make sure that you document everything properly, and patient's education is very important, and you have to give the important message, like in that ROP case. Yeah.
No, actually, people who are doing casualties, I always tell, put the time of your examination, and put the time whenever the patient are coming to the theater, and always take a photograph, even lid, whatever thing, pre-op. But none of you do those things. That's a problem. So, because those will be the sort of validated things afterwards. That will happen.
They get that. I can remember I was a member of one inquiry conducted against one gastrointestinal surgeon, that after cholangiogram that something happened. So once doing inquiry, we got that big BHT. Each page we discuss what is happening, at what time the consultant came after complaint, at what time that consultant ordered this investigation, and at what time blood has been drawn, and what time report received, and what was the response done. Like that continuously we have taken. Okay. Then other thing is, in the private sector, same case, we did same way. After doing all the inquiry, they have taken that BHT, these flying squad people, they started to investigate. Official time they have taken their diaries. Okay, and at what time they have attended to private sector. They are trying to catch different ways, not only from negligence side. Be careful about those things. What we are doing now, I am also doing that private looking patients. Now I am not putting private hospital time, I am not putting. My case is not emergency, that is not problem. So to escape that, after that I am not putting time, only date.
One other case actually going on nowadays. One patient underwent cataract surgery a few years back, 2 to 3 years back. Had used some prednisolone acetate, which was problematic on the eye hospital. So patient was got to court because of this prednisolone. My eye sight was vanished. So the indication was, during the surgery, patient was a glaucomatous patient, and finally after the surgery we have sent for the SLT, and it was failed, and some branch vein occlusion or something like that. They have gone for a IVB injection. Anyway, patient lost the vision. But the patient was caught because of this drugs. Patient, I have vision, lost the vision. So ministry has sent us a letter whether you use this prednisolone for this patient or not. Actually, I check all the BHTs and all things in the ward. You have not used, but clinic visit we have given this kind of prednisolone. So we have not place to write or give our decision regarding the vision loss is probably not due to the prednisolone, but ministry is asking whether you use the prednisolone or not.
There is a probability. Here that is called vicarious liability in medical negligence, that we are putting that burden to sometimes to medicines and instruments, staff and other things, but clear case this low quality drugs even. So that is why once they identify, I can remember when I was in Vatupitiwala, that eye surgeon used to bring one bottle that look inside foreign bodies are there. Okay, so that is what. So that once you put those things, there are problems arising. So that responsibility is going to there. That is why we have to document those things in the BHT. What is that? The problem is that once that drugs coming in batch number, that is the one we give to patients, that they can find out from the hospital, not from the eye surgeon or IMO, that is the particular drug giving. So in this case that they wanted to know whether prednisolone given or not, that is to see that whether to match that one, not to catch you.
My question is, this kind of situation, actually we know some difference in drugs. Even the prednisolone acetate is available in the hospital. Can't we give some proper brands?
No, that is according to that government regulations can't give. You can ask from Dr. Dayavansha what he has faced problems while in Polonnaruwa.
Thank you, sir, for enlightening us on the medical legal aspects of ocular trauma. Your insights have highlighted the crucial intersection between medical care and legal considerations. Now, the College of Ophthalmologists of Sri Lanka and Association of Vitreoretinal Specialists of Sri Lanka would like to present a token of appreciation to Dr. Ramesh Alagiyawanna for your invaluable expertise that you have shared with us today. And to deliver this token, I would like to invite Dr. K.R. Dayavansa. Thank you, sir. As we come to the conclusion of today's session, it's time to express our gratitude. To deliver the vote of thanks and acknowledge all who have contributed to the success of this symposium, please join me in welcoming Dr. Chaya Samarasinghe, Joint Secretary of the College of Ophthalmologists of Sri Lanka.
Good afternoon, everyone. So as we come to the end of yet another workshop, I wish to thank certain special people who worked tirelessly behind the scenes to make this happen. First of all, I wish to thank the President and the members of the Associate of Vitreoretinal Specialists of Sri Lanka, who were one of the biggest forces behind this, and especially to Dr. Aruna Fernando and Dr. Lalanta Gurusinghe, who were the coordinators and organized this so well. To the speakers, I would like to extend my special thanks, starting from Dr. Ranjit Ellawala, Consultant Surgeon, KDU Hospital, Ratmalana. Thank you very much for being here on a special holiday to share your knowledge. Dr. Ramesh Alagiyawanna, Consultant JMO, North Colombo Teaching Hospital. We are very grateful to you for being with us here today and for that very interesting and enlightening talk. To our own local faculty, Dr. Medhavani Disanayaka, Dr. Aruna Fernando, Dr. Lalanta Gurusinghe, Dr. Kapila Bandatilaka, and Dr. Nirodha Jayavikrama. Thank you very much for all the presentations done. I also would like to thank Mr. Chanaka and Elkan Surgical team for their generous sponsorship of this event. And thank you very much to Mr. Prasad and team for their assistance with the sounds and the presentations. Thank you very much to the Director, National Eye Hospital, for providing the auditorium. And finally, to Ms. Kumari Gunawardena, Secretary, Association of Vitreoretinal Specialists of Sri Lanka, and to Ms. Hemamali Vevalvala and team of College of Ophthalmologists of Sri Lanka and the college staff for the assistance backstage. And lastly, thank you, all of you, for being here, for making use of this wonderful presentation and sharing your enthusiasm toward the end. Thank you very much. And please, your lunch is available outside. Take it when you go out. Thanks.